All right. Good afternoon, everyone. Can you hear me? Can you hear me okay?
You're
Thumbs
good.
up. Excellent. I love it when a plan comes together. All right. Let me share my screen for you guys. I didn't want to ruin the intro slides. Those were delightful. There we go. Great. Okay. Plan still came together. Excellent. All right. Well, thank you so much, Kelly, for that beautiful introduction. And thank you guys so much for having me today. I'm Dr. Bojarski, but all my patients and all my colleagues know me as Dr. Bojo. I'm a memory care neurologist here at UK Sanders Brown on Aging. I am completing my geriatric neurology fellowship. So we get to spend a year after training devoted to memory things such as dementia, and other memory problems. So I've gotten to learn from Dr. Jaika and the whole team about resources and ways that we can best take care of our patients and our loved ones with dementia. So today's going to be a little bit of some insight as to what we have to offer, some insights as to how we can best care for and support our loved ones. So without further ado, let's get into it. So when we talk about brain organization, we talk about different parts of the brain do different things. And when we talk about dementia, certain parts don't do certain things anymore. So, a brief overview to what the brain does, we have our frontal lobe, which is important in thinking, behavior, and movement. We have the kind of backside of our brain, which is called the occipital lobe. And ironically, that's where sight is interpreted from our eyeballs. We have our parietal lobe, which is kind of on the sides here. That enables us to sense where we are in place and time. So language and touch is also there. And we also have the temporal lobes. That's primarily with learning, feelings, hearing things, right? Our ears are on the side of our brain, and that's where the temporal lobe is. It goes straight there. And then we have our cerebellum, which is really important for balance and coordination. And then we most primitively have our brainstem, which is in charge of keeping us awake and breathing and things like heart rate and temperature. So, a very brief, very simplified overview of the brain, but I think it's important for when we talk about dementia, where certain parts of the brain do not quite act like they should. So, before we go too much into the weeds, I want to just discuss some definitions because when we talk about cognition and cognitive impairment and dementia, those are a lot of different words with different connotations. So, when we talk about cognition, that's just the mental action of getting knowledge from the world and understanding it through thought, experience, or the senses. So, how we interpret the world. When we talk about something like a mild cognitive impairment, that's a cognitive decline, but we're still able to do everything that we want to do in the world by ourselves. So, for example, someone comes into the office and they say, "Hey, I have a memory problem. It's not interfering with my life. I don't need help with my medicines. I'm still able to go to doctor's appointments without any help, but I can tell that there's been a decline in my memory." That's a mild cognitive impairment. We contrast that with a dementia, which is a cognitive decline in one or more domains that we talked about where the brain is: memory, language, attention, how we process things in space and time, or social behavior. And that would impair daily functioning if it's dementia. So, for example, I have a memory problem and I can't do my medicines by myself anymore. I need help from a family. That would be considered a dementia. So those are some definitions that are really important that we understand as we move through. Dementia itself is an umbrella term, hence the umbrella with little raindrops below. When we talk about dementia, we talk about a syndrome of symptoms, but what causes it is what's underneath the umbrella. So we can have dementia, but we can have a lot of different things, one or more as listed below, that can be causing the dementia. Is it Alzheimer's disease causing dementia? Is it Lewy body disease causing dementia? Is it vascular disease causing dementia? A lot of different things, and possibly more than one, can cause someone to lose their ability to interact with their environment as well as they did before. So, when we talk about the progression of a dementia, I've included the typical progression of Alzheimer's disease just because it is the most common. But at the top there, you can see time. So, as time goes by, the years go by, we are able to evaluate how someone functions with their interaction based off their cognitive function, which we can see in clinic and based off of family members telling us what's been going on in their lives. So, we can see in the preclinical stage, we can even see that cognitive function, while it could be normal, the brain of an Alzheimer's patient is already starting to experience changes even 15 to 20 years before they actually can experience true cognitive impairment. So, preclinically, we can see changes in the brain, but at a certain point of time, the brain starts to compensate for those changes. That's where we get to mild cognitive impairment. At a certain point with the disease, you start to kind of exponentially deteriorate, and that leads to the dementia, which is the cognitive decline leading to the loss of independent function. and ultimately that diagnosis. So when we talk about Alzheimer's disease, like I said, it is the most common neurodegenerative cause of dementia. Typically, episodic memory is first to go. Well, what does that mean in everyday life? Well, like I had mentioned earlier, missed appointments, having forgotten some conversations that had happened before, forgot having done something. Say, for example, a week or two ago or a month ago, you went on vacation and you can't remember certain aspects of that vacation. That could be concerning. This can progress ultimately to wandering, getting lost in the middle of the night, decreased work performance, word finding difficulties that are worse than they were before. So on the right, I have some Alzheimer's cells. That's showing that buildup of amyloid plaque and tau tangles. And those are forming from healthy cells. It's just plaque buildup. It's trash buildup over the years. So we're trying to figure out ways to clear that trash. And that's where some of our current infusions and medications are really having their action in the brain. And below, when we take the brain to autopsy, we can even see those tangles and plaques already in the brain tissue. And so this is what we're trying to stop. This is what we're trying to prevent. Now, a lot of times I get questions, well, I have some things like I forget names of people I just met, but I'll remember their names a couple minutes later. That's normal. That happens as we all get older. Even now, that can happen if forgetting names of people you just met. But what could be abnormal aging is forgetting names of your children or your grandchildren or people you really should know the names of. Like you've worked at the same place for 30 years and you know those people, you really should know their names. And so forgetting those kinds of names can really concerning for us. It's normal for you to go into a room and forget you were going to say or why you came into a room. That's normal. But if you forget the steps to complete a common task, that can be concerning. Other things, that are normal are forgetting where your car keys are. If you have occasional difficulty with word finding, forgetting the day of the week or where you were going, you're retired, you probably are not super inclined to know or remember which day of the week it is. But if you are becoming lost in familiar places, or you can't remember the month or the year, or you have difficulty with word finding that interferes with your communication, or you can no longer manage your medicines or go to doctor's appointments without help, those are things that are considered abnormal aging. So I've listed them here. I think the slides will get sent out later. But these are important things because obviously we have normal aging, normal forgetfulness that's benign, occasional, but if it's getting worse or it's persistent over time, that's the time to seek some help. So when you come to a clinic appointment for us, if we're suspecting that you have a memory concern, this is how the typical flow will go. So we get the memory consult from memory complaint. So we get that information from your physician, they refer you to us, and then our schedulers will then call you, set up a time, and you'll come in. Now, granted, there's not enough memory care neurologists to go around. So unfortunately, the lengths can be kind of long to see us, but all the same, we get that consult, we try and get you in as soon as we can. And then on the day of your appointment, we will do a neurologic and cognitive evaluation of you. That basically, and I'll go into detail about what specific things that we'll ask, but we'll do a history. We'll ask you about what's been going on. We'll do a physical exam, make sure heart and lungs are okay, make sure your neurological exam is okay. We'll do an evaluation of your brain to see which parts are not working. Remember that brain map that I showed you on the first slide? We're going to give you a little test and see which parts aren't working quite the way that they should. After that, we'll discuss with you if we need any imaging or labs and whether we need further testing based off of the results that we've got. After we're able to get the MRI, or any neuroimaging and labs, we'll then be able to tell you whether you have a diagnosis of dementia, which type. For example, what's causing the dementia. That's the whole point of coming to see us, is what type of dementia or memory problem do you have, and how can we fix it and treat it? So there are several barriers to diagnosis. Obviously, if someone's unaware of symptoms, they don't know to ask for help, and therefore they won't be able to get help. So being aware of symptoms, like I said, with the normal aging versus abnormal aging is really important for the population to know so that they can know to ask for help. Evaluation is not easily attainable. Like I said, our wait list is very long. So getting in early is really important, especially now that we have medications that can help prevent / treat early. It's really important. Evaluation can be time consuming. Obviously, y'all are a little bit ways away. So driving to, being at the visit, and driving back can be time consuming. The belief that memory loss and cognitive decline are normal, it's not. There are normal aging things, but there are concerning memory loss and cognitive decline changes. So we need to be aware that those exist and can be treated. And then also there's a belief by some clinicians in the general public that Alzheimer's disease can't be treated. And we know that's not right now. As of 2023 in July, we now have medications that attack the amyloid at the source. So it's a really promising way for us to start experiencing treatment for the Alzheimer's population that we never had before. So what does a cognitive and neurologic exam look like? Well, I have on the right here a little reflex hammer and some muscle testing. Obviously, we'll give you a thorough neurologic exam, make sure that there's nothing like a stroke or something like Parkinson's that could change our differential for the diagnosis of what might be contributing to the dementia that you might have. And on the left, we have a whole bunch of ways that we can evaluate your brain while we're in the clinic. So we don't need to send you for a 4-hour exam necessarily if we can get what we need on here. And this will test things like memory. It'll test things like your language. It'll test your math, which I always do not do well at. But a lot of different things that will tell us different parts of your brain. Are they working well or not? So what kind of labs might we draw? Well, we typically will draw blood. We are looking for vitamins and minerals that might be low. Those can contribute to memory problems. We also look at your thyroid. We make sure that there's nothing else that could lead us to a different diagnosis. Some things are case by case. And then sometimes we might do cerebrospinal fluid, which is a lumbar puncture. If you've ever had an epidural, they put pain medicine in, and it's the same procedure. We just take fluid out, and it's the fluid that bathes your brain. So we can test for Alzheimer's in there. Insurance is allowing us a little bit more easily now to do amyloid PETs, which are basically images of your brain that show amyloid, because we can't typically see it on an MRI or a CT scan. And by typically, I mean never. So we always look for an amyloid PET. So that's a little bit easier. It's not, a procedure. So once insurance is able to get on our level, then we'll be able to do more amyloid PETs. But just suffice it to say, you might be required to do a cerebrospinal fluid tap. And because if we're looking for something else that might be concerning, that's going to give us more information than just one of those other imaging findings. So like I said, I was talking about the amyloid PET, the MRI. Well, what are those? Well, they're all imaging modalities. If you've been in that little donut of truth, if you go into the emergency room, they put your head in a circle. That's usually a CT scan. And then if it's enclosed off and it's going da-thung, 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 that's an MRI. So typically, for our purposes, we need a 4K high-def picture of the brain. And an MRI is going to be the best way for us to do that. A CT scan is like an old school black and white photo. Doesn't quite give us everything that we need. So an MRI is typically warranted. So in here, you can see clearly the difference between a healthy brain and an Alzheimer's brain. Do you see there's more black in the picture overall? There's more space filling the brain. The brain is supposed to be white and plump and juicy like on the left, but on the right, we're starting to see more black. And that just means there's atrophy in certain places that we know are commonly associated with Alzheimer's. We have an amyloid PET in the middle. That's showing us where there's a lot of amyloid plaques. Remember back when I was talking about Alzheimer's disease, we were talking about plaques and tangles. Well, this amyloid PET shows us if there's plaques and tangles. And if there's plaques and tangles, then there's Alzheimer's. So this is the easiest way for us and the most non-invasive way to look for amyloid in the brain to see if you have an Alzheimer's disease. And as you can see in the picture below, it lights up really bright if there's Alzheimer's disease. And then an FDG PET is really interesting because it tells us where there's atrophy of the brain. In the red, orange, hot places, the brain's a really active muscle, right? It's always working. And so we want the whole brain to look active, hot, and really good. But some places we see where it's cool, it's blue, it's cold. And those are not ideal because that means the brain's not functioning quite where it needs to be. And that can give us an indication of what might be going on. So all of these things are very important. And these are just most common. Obviously, we can use others, but those are the things that you'll most commonly see. I include this picture not to go on at length about it, but just to show you again that when we go through time, we can detect Alzheimer's now very early on, like at the earliest time that you're having memory complaints. We can now test you with blood biomarkers that was just approved through the FDA. We can evaluate it through the amyloid PET that I just told you. We can look at it through your lumbar puncture. So there's a lot of ways that we can evaluate for Alzheimer's now, and it's getting easier every day ever since the FDA approved the blood biomarkers. So we're really excited about that because we're going to get a lot of people on treatment early, which minimizes your side effect profile for these medicines, in addition to potentially having the the idea that you could hopefully prevent Alzheimer's forever. Now, we don't have proof of that yet, but that's the idea. That's the whole point of like a vaccine, is to prevent this from even accumulating so that we can get like straight in there, get it out, and you never have to worry about it. That's the goal. That's the dream. We're not there yet, but that's the dream. So when you come into the office, when we do that cognitive testing, we get a score. Those scores correlate with functional ability. So when we ask you, hey, how is your loved one doing? You know, are they still able to do finances? Are they still able to keep appointments? If they are, and they score an MMSE, which is one of our cognitive tests, and they score in this 20 to 25 range, we can tell that they have mild cognitive impairment, which means that they correlate with the ability to still do their activities of daily living. But then as it progresses, we can see as those cognitive test scores go down, we can tell that they have loss of, independent performance. And that's when we start to get concerned for dementia. So just showing the correlation between how you guys see what your loved one is dealing with versus what we see in the clinic, because we're not with you every day. We don't see what you see. So it's really important for you to give your history of what's been going on, and then for us to cognitively test them to make sure we're on the same level. Because if you're too far down on one of these cognitive test scores, you may not qualify for one of the treatments that we have because it'll be more dangerous. So it's really important for us to get on the same level. We do have oral medicines for memory loss. These are used at all stages of Alzheimer's disease specifically. Some are indicated for other pathologies like vascular dementia or Lewy body dementia, but all the same, these medicines are typically used for memory loss. One of them is a cholinesterase inhibitor. It's just a big word that just means we like to spark your brain with acetylcholine. The brain loves acetylcholine. It's a chemical in your brain. And donepezil and rivastigmine are the generic names. Those will help stimulate it. They actually did this test in college students where they gave this medicine, the donepezil or the rivastigmine. They actually gave this medicine to college students, and they all bumped up half a letter grade. So it really does just help to boost the brain metabolism. Now, don't all y'all go thinking that you can just have it, but because it is still, you need to go to the doctor and do that. But just to say that this is really important for those with early Alzheimer's, like in the mild cognitive impairment stage, because we can really help boost their functioning and give them better quality of life. An NMDA receptor antagonist, another big word that just helps us to improve the ability to perform simple tasks when we've gone into the dementia diagnosis. So we're having troubles with our daily function. We know that the Namenda or the memantine is helpful for people to help with their daily living tasks, as it were. This slide, I'm not going to go into too much, but just to say that we know that if you are on donepezil, it helps. But then when we take it out, you go back down to where you were not functioning as well. It's not quite as bad as it would have been if you had never started it. So it does have effects for as long as you're able to use it. But ultimately, you're able to use the donepezil. We can tell it helps. But then when you stop using it, we can tell that you're still better off, but not as great as you would be if you were able to continue the donepezil. And then this slide shows you that when you use donepezil and the memantine, those two drug classes that I just told you, they actually have a synergistic effect, which means that they add on to each other. So each one alone is not better than the sum of its parts. So when you combine them together, that's a lot better off for your patient or your loved one than it would have been on either one alone. And we can see that the functioning of someone slows down. That top blue line shows that they're slowing down on their progression versus that salmon color on the very bottom, which is with no medicines. You can tell that over time, they're getting worse quicker versus if they were on both of those medicines. So that's the optimal oral medication regimen, is both the donepezil and memantine. So that's why a lot of people that you'll see if they have memory problems, they're on both. Now, I was talking to you about a lot of the infusions and how we're trying to kick out that amyloid. These are those two medicines. They were just FDA approved in 2023 and 2024 respectively. Kisunla was the more recent one, and Leqembi is the other one. These are monoclonal antibodies that basically attack the amyloid in your brain. They cross over into your barrier, into your brain, and they take out the amyloid and you pee it out. That sounds great, right? Well, it's not a cure. We know that amyloid is a trash product. We're still trying to get at why this actually happens. We think there might be some early on things, or it might be that we need to attack several things at once. But this is a great way to slow progression of Alzheimer's by anywhere from 6 to 9 months over the 18-month trial that they did. I say it slows in about 6 to 9 months. That was only in an 18-month period. If you take this medicine, say theoretically for 5 years, that could be 2.5 years of quality of life that you got back. So just thinking about, the earlier we get people on this medicine, the longer they can have quality of life. Again, not a cure, but slows the progression of about 30%. Leqembi is an infusion every 2 weeks, and after 18 months, you can switch to monthly. And actually, in August of this year, they have already submitted to the FDA to do subcutaneous belly injections weekly after you finish your 18 months. So you may not even need to go to an infusion center anymore. You might just be able to do it at home. We obviously need the FDA and insurance to approve that before we can get that to happening. But that's really exciting in this field. I mean, we are flying by in the advances in these medications. And so while this is just a start, we're really excited about the future that it holds. So these medicines that I talked about, these infusions, are not for everyone. The oral medicines are typically for the most of the population, barring some side effects, but these infusions are not for everyone. Both come with potential side effect of ARIA, which is a cool nickname for amyloid-related imaging abnormalities. These can look like swelling in the brain or bleeding in the brain. So obviously those are really scary for us, and we don't want that to happen. So you have to be able to get MRIs to make sure you're safe. So some people with sacral stimulators, lumbar stimulators, bladder stimulators, sometimes those people cannot get Leqembi or Kisunla because they can't get MRIs. Now, if you have a pacemaker or defibrillator, those might be MRI compatible. If you have like a VNS or an RNS, those again can be MRI compatible. Those are okay. But some of these things don't allow you to get MRIs. And for that reason, you wouldn't be able to get this medicine because we need to have very frequent MRIs at the beginning to make sure that you're safe. It also can't be done in the later stages of Alzheimer's disease. Think about it. If you have a moderate to severe presentation of Alzheimer's disease where you're having difficulty with, even dressing or eating, your amyloid has built up so much that if we were to take it out, it would be detrimental to you or your loved one. And so therefore, the risk of harm would be greater than the potential benefit. And so if you score a certain number on that cognitive testing we said earlier, we don't recommend that you get it because it's really important that we keep you safe and we don't hurt you. A lot of people are talking about ApoE status, which is the genetic test for Alzheimer's. This does not mean that you have Alzheimer's. This only determines your risk. So I have here that people with a first-degree relative with late onset Alzheimer's disease, they actually only have a 1 in 4 risk of having Alzheimer's disease lifetime. A lot of people say, oh, my mom and dad had it, so that means I'm going to get it. That's actually not true. Your parents having it definitely increases your likelihood, but that's why we do this genetic testing. It tells us how high your risk to get it is. I've seen people who have the genetic test that says they have high probability that they would get it, and they actually don't end up having Alzheimer's. So we've seen both ways. When we talk about ApoE, we're talking about E4. E4 is the one that increases your risk for Alzheimer's. E2 is actually preventative. So when I talk about genetics, you have 2 alleles. When you were born, you had 1 allele from your mom and 1 allele from your dad. And that tells you your genes. So if you have an E4 from your mom, that increases your risk about 30% of getting Alzheimer's. If you have if you got an E4 from your mom and E4 from your dad, that's about a 50-50 shot. Not only does that tell you the risk of getting Alzheimer's, it also tells you the risk of ARIA, which is why we do this genetic testing before we start you on a medicine like this. We need to know, and we need to tell you and help you understand that you will have an increased risk of ARIA if you were to get these amyloid medications, these anti-amyloid medications. We do not recommend testing for those that are asymptomatic. That is a genetic counseling thing, and that goes to a separate place. So for example, if you're coming to the memory care and you just want to be tested, but you don't have any memory problems, we don't do that. And actually the guidelines for the American Academy of Neurology do not recommend testing in asymptomatic individuals because it won't change management. If you're asymptomatic and you have a positive ApoE, we're not going to treat you with anything because you're not symptomatic. We don't have any vaccines currently, so it really wouldn't do anything if we test you. It'll just worry a lot of people that they might have it in the future. So we try to stay away from that, at least for now. In the future, it might be different. The risk of side effects with lecanemab, a lot of people ask me this, so I have it here up on the slide for you guys to refer back to. Most of the time, any ARIA that we had, which is the side effect that we look for, most About 91% were mild to moderate. They didn't even know that they had ARIA, and most were asymptomatic. Like I said, they didn't even know they had ARIA. We caught it with MRIs before it got bad. So that's the whole point of us doing all the MRIs, right? We want to make sure that we catch it before anything happens, before you start to feel side effects. That's the whole point of the MRIs. Now, obviously, if you're E4, we talked about that being the higher risk for Alzheimer's, higher risk for ARIA, you can have up to a 40% chance of getting a bleed in your brain if you do get this anti-amyloid medication. So again, we're looking at your MRIs, we're making sure that you're safe, and these are all things that we really want to go deep into detail with when we talk about this medicine with you, because it can be dangerous. Like I said, for the most part, very safe for most people. But if you have one of these higher risk profiles, then we need to have a discussion about what your goals are for treatment. So that's all the treatment standpoint for cognitive impairment and dementia. But let's talk about some behavioral symptoms, because I'm sure that you guys probably have seen that when we start to have dementia, it starts to worsen. We can tell that there is a mood change, there's a behavior change. So this picture is really cool, and I really like it because on the left side, you see it's the frequency of patients. So the higher up you go, the more frequent it is. The months before and after diagnosis, time zero, that red line, that's the diagnosis date. And you can tell that to the left of that line, those are things that people are experiencing even before they're diagnosed with a dementia or mild cognitive impairment. So things like anxiety and depression are important, but changes in your sleep cycle, those can happen early on, even before we're diagnosed. And then obviously afterwards, you can have more wandering, agitation, aggression, hallucinations, things like that as time goes on. Some causes of these unwanted behaviors are maybe, unmet needs. So I have on the right here a whole list of things that we find very commonly at the home is inadequate lighting. When's the last time they had a vision test? Is there new surroundings? Are there too many demands? Is it too stimulating for someone to be doing puzzles here and going to the mall and then going to the doctor and doing all these things? Is there a lack of daily structure? People with dementia tend to have muscle memory. They might lose their episodic memory, but they have muscle memory. So they remember doing things every day. And that's really important to keep the mind active. The mind likes to be active. Are they too bored? Are there any feelings of thirst, hunger, pain, distress, feelings of abandonment, fear? Those are all environmental factors that we can fix. And we can redirect in order to fix them. So we always try and redirect if they're getting agitated or aggressive. We try to say, you know what, I understand you may not be able to tell me what's going on, but let's go over here to this nice calm area with good light. Make sure that you are not in pain. Make sure that you have enough water, because a lot of us don't drink enough water at baseline. And when you have dementia, you forget that you've not drank. So that's really important to remember. Like I said, redirection is really important. We always treat the dementia first. Typically, a lot of our patients who get agitated, their memory is not optimally, it's not optimized with oral medicine. So we do the donepezil, we do the Namenda, the memantine, and then after that, we make sure that we're intervening on their behaviors. So we want to make sure there's a secure and safe environment. We love routines. I can't tell you how many times Sarah and Kelly have told me that routines fix most of the problems that they've seen. But having breakfast at 7 or whenever you wake up, and then puzzles at 10, lunch at 12, walk at 3, going to a weekly church group, especially one that's dementia friendly. I know there's several here in Lexington that advertise that they're dementia friendly. So finding a group that really supports you is really important, and encouraging constructive activities, both physical and mental, whether it's picture books, whether it's listening to music, whatever you can do to meet someone, where they're at. And with social interactions, it's important for us to have social interactions as well. Making sure that we're going to the medical doctor's appointments, making sure that physical ailments are addressed as much as we can, and supporting caregivers, supporting loved ones, making sure that they have the mental bandwidth to take care of their loved ones, because communication through body language can very easily be picked up by someone who has impaired cognition. So it's really important for us to take care of caregivers, because we know that caregiver support is super important, and it's very prevalent to have caregiver fatigue. Ensuring adequate nutrition, hydration, and sleep, like we talked about. So when behaviors become an issue, meaning when behaviors start to become severe to where the safety becomes compromised, that's typically when we will step in to suggest medication. There are limited FDA-approved treatments. Most of the medicines we used are tailored to a person on a case-by-case basis. So we will prescribe them even though they're not FDA approved, because we have colloquial knowledge, like from other neurologists that we go to conferences for, that say, hey, I use this in this person, and it really helped. For example, things like lamotrigine, Lamictal, that is a mood stabilizer. That can be really helpful in someone who has some agitation, maybe some anxiety. That can be really helpful. Unfortunately, when things get really aggressive and maybe there's a psychosis like hallucinations or something, that distresses the patient and the person, then it might be really important that we start another medicine. The medicine I'm talking about is an antipsychotic. Antipsychotics in the elderly can be dangerous. There was an increased risk of death in the drug-treated patients who had the antipsychotic, and this is like quetiapine, the brexpiprazole. You guys might have heard of the Rexulti, which is the newest FDA-approved medication for Alzheimer's disease-related psychosis. That does come with a black box warning, which is what the FDA gives out when there's an increased difference in people dying in the trial. So the odds ratio is 1.54. So there is an increased risk. It's little, it's about a 1% increased risk, but it's still there all the same. A lot of people tell me that when it gets to a certain point with their dementia, they're so agitated and their loved one doesn't mean it, but they're knocking on the door and they're banging on the door and the caregiver feels very scared. That's the time that we would start one of these medications that are more dangerous. But again, there's a lot of other medicines that we can use that are not dangerous that we try first if it gets to that point. So if there's sudden behavior changes, then you want to call a clinician for help. There could be a urinary tract infection. There could be, a sickness that they're fighting off, and they could be delirious. So we want to always make sure that there's nothing else going on because they may not be able to tell us what's happening. And lastly, I always recommend people to keep a behavior journal, noticing times, any triggers or certain behaviors. I had one patient who came in and they said that every night at 2 a.m. they would get hallucinations when they would wake up. And he had prostate issues, so he would be waking up to go to the bathroom, but he would hallucinate things on the ceiling because there would be shadows from a nightlight that they had. And actually all we had to do was change where the nightlight was. So instead of it being in the bedroom, we put it in the bathroom and his hallucinations went away. We didn't have to do any medicines. So meeting people where they're at and making sure we identify those triggers, especially when you come see us in clinic or talk to your provider about it, is really important because that way we can help meet you where you're at and maybe not even have to do a medicine like we did for them. So some common misconceptions that I wanted to address today that I've actually gotten when we were doing the family caregiver workshops. I added these in after I had heard a lot of good questions. Alzheimer's can only be diagnosed at death. That used to be the way. It used to be that you could only diagnose it at autopsy. That's not true anymore. I hope I've convinced you now during this presentation that you can get blood, you can get CSF, you can get an amyloid PET. Those will all tell you if you have Alzheimer's or not. So that we can treat you early on. My loved one can no longer make decisions after diagnosis of dementia. That's actually not true either. When we talk about medical capacity, you have to express to me that you can understand what the treatment is, the risks of stopping the treatment or persisting on the treatment, and alternatives. If you can tell me those three things and keep a solid argument, even if you have some memory problems, even if you have dementia, you can still make those decisions for yourself. And I actually just encountered this a little bit ago where we were having someone who didn't want to do the Leqembi infusions, but the family did. Ultimately, it was his decision because he had the capacity to do that, but it was really hard for the family because their values were not aligned. So honestly, we try to treat the patient and whatever they would want for them, whatever they want for themselves, if they still have the capacity. Obviously, we trust the family to make decisions once they no longer have capacity, but that's definitely something that goes into our treatment plans. The other common misconception is that there are no treatments for Alzheimer's and dementia. I hope I've convinced you that that's not true either. We have several medications. We have more medicines coming out. We have more clinical trials. We're really excited. We're on a roll. We are on our way to a vaccine. We are on our way to a treatment and a cure. It's only a matter of time. We are doing really well. We're really excited about this momentum that we've built for Alzheimer's disease prevention and progression. And with Alzheimer's disease prevention, we are now able to look at different other dementia types like Lewy body and vascular dementia. And now we're doing more research on them to see how we can fix them all. So really exciting time for memory care for us. Another misconception is if a parent has dementia, that children will also get dementia. Again, that's not true. I hope I've convinced you that genetic testing just tells you your risk for and your likelihood for, but it does not tell you whether you will get or will not. There's only 3 families, I think, in the world that have an autosomal dominant, truly genetic inherited dementia, and I believe they're in Chile. So we don't typically have anything like that here that is completely inherited 100% of the time. And then a lot of people are asking me, there was a couple news articles that Alzheimer's is diabetes type 3. We do know that there is a correlation between diabetes and dementia. Typically, diabetes is the thing that causes a vascular dementia, but not necessarily an Alzheimer's disease dementia. There's more research going on to see what the correlation is between diabetes and Alzheimer's, but that is still underway. It's not necessarily the same thing right now. We're just doing more research for it. So with all of those misconceptions, I hope that I've been able to hopefully answer some of the things that I'm sure that were being wondered about, but I wanted to hear if you guys had any questions for me. I know that was a lot of information.
All right, there we go.
There we go.
Okay, my name's Elsie Lilly, and I take care of my sister, but she's like a child. I mean, she does nothing for herself. She can't dress herself. The only thing she does feed herself, but I make finger food, you know, that because she uses her hands. She does no longer use utensils. Is it too late because she can't communicate with you? She can get a word out and then it's like jabber and then it'll be another word. Are there anything that is left to do for her that she's in this late stage?
That's a great question and something that I get all the time. So excellent question. There's always something we can do. Even if it's in the supportive aspects. It sounds like this would be more of the supportive aspect, making sure that she has resources, making sure that you are getting caregiver respite as much as we can in the area. If there's like a daycare or something like that, looking at resources that your primary clinician might have. There are other medications that can be used. For example, the donepezil and the Namenda, those might help her even at this late stage. It might help with day-to-day functioning a little bit. Probably wouldn't see too much of a effect, to be honest, but still could be worth a try if you were wanting to try something. It would be too late for the infusions, but yeah, things and I don't know her personally. I've not done her exam, so I can't give out official medical advice. But ultimately, it sounds like she might be too late for the infusions, but definitely could potentially benefit from the oral medicines, and again, at least some support from a resource standpoint as well.
She takes Arifac and Rexvalda. I don't know if that's exactly how you say it, but she takes those 2. But all she wants to do, she don't sleep. I mean, she don't sleep for 48 hours. I mean, she can be up for 3 days, 3 nights, straight.
That's but another thing that
walk. She walks with her walker.
Mm-hmm.
How do I get her to calm down? I mean, I bought baby dolls, I bought all kinds of stuff, try to keep her interactive, but she has no desire for those. Are they anything that I can get her just to, sit down and rest a while? Because you can tell how tired she is, but
yeah,
she fights you.
It sounds like she might have some anxiety, and it's something that you might want to tell your primary care doctor about or your neurologist who's following her, that she might have some anxiety. There's some medications that we can offer her to see if that would help her to calm down, because it does sound like she's tired. It does sound like things like that. So there are definitely some things we can offer from a clinician standpoint for her. But yeah, I would recommend reaching out to your primary care and saying, I'm experiencing these things. Is there any medication that we can do? I say that in addition to the fact that Sarah and Kelly and our social work team, they might be able to have some information later on today in this caregiver workshop that might give you some more resources and how to deal with that aspect of taking care of her.
The chat had mentioned, is there any type of nutrition that's good for Alzheimer's disease, which I thought was a great question.
That is a fantastic question. Let me finish reading it. Recommended foods and foods patients should have less. I am thinking about this because it is so common for older people to have gaps in macro and micronutrients. Absolutely. Also, I know inflammation is bad for the brain. Absolutely. Would insurance likely cover a nutritionist that would make a meal plan? So I'm going to answer the first question first. You're absolutely right. We know that vascular dementia is one of the things. There's 40% of dementia that could just be completely reversed and prevented. It's things like making sure that your hearing is okay, making sure your eyesight is okay, making sure you don't smoke, making sure your blood pressure is under control, making sure that your cholesterol is under control, being on medicines for that. But the other 40% of that part is food. We know that exercising 5 days a week, 30 minutes, I hate to be a broken record because I know you guys have heard this all the time, but that is actually one of the best things that we have to preventing dementia. That, in addition to food, it's called the MIND diet, but it's basically the Mediterranean diet. It's a diet low in fat, low in red meat, high in protein, high in fiber. So things that are kind of hard to come by, honestly, in certain parts of the nation and even the world. And so I understand it's not always realistic to have that mindset of, whole foods, things like that. But that is something that reduces inflammation just in general. I always typically recommend staying on the outsides of the grocery store where all of the vegetables and fruits are, trying to avoid the inner parts, which is where all the frozen and processed foods are, if you can help it. But that's a great question. And then would insurance likely cover nutritionists that would make a meal plan? They won't cover a nutritionist, but they will cover, I believe, for a dietitian. I know at University of Kentucky, we have dietitians that I will typically refer my patients who are having trouble eating. They'll typically go there and they'll get recommendations for how much boosts should they have per day to meet their calorie requirements. Now, unfortunately, we get to a certain part of dementia where people just don't want to eat, and forcing them to eat causes more stress for both you and your loved one. So we typically, when it's that late stage, we'll typically just say, hey, just support them. If they're hungry, they'll eat. If not, that's okay. They don't get very hungry at the end of their dementia process. But for the main part, in the earlier parts of dementia, we typically will recommend a dietitian just to help with that component. So excellent question, Katie.
Any other questions in the room for Dr. Bojarski?
I've got a question.
Mm-hmm.
My husband, his memory loss is due to strokes. He had 3 strokes 6 years ago, and it affected his vision. He can't see the right side out of either eye. And his memory, long-term and short-term memory loss. He's pretty well he does not want to go anywhere. He doesn't want to do anything. Sometimes he can remember our kids' names, our grandkids' names, but not all the time. But his dreams, when he wakes up, whatever he's dreaming about is just so real to him. And I just go along with it. I don't know what else to do. It's surreal that I have had to go out of the house just to say, hey, I went and checked. There's nobody out there, things like that. I don't even know if this is the right. It's like dementia, but I don't know how to explain it.
Dreams can be part of dementia? Or how to handle the dreams that feel so real?
Yes.
That's a great question. A lot of my patients' loved ones tell me that that's happening to them too. At that point in time, I typically will ask during the conversation that we have when you're in the appointment, whether those hallucinations are bothersome to the patient. If you go outside and you say they're not there and you come back inside and they're okay with that and they're back to normal, then that's typically how we address them. I don't want to put on a medicine to potentially hurt the patient if their hallucinations are not bothersome. Now, if they're bothersome, like I feel like there's an axe murderer coming to me and I'm terrified, then yes, we will start medication for that. That could be more dangerous. But for the other side effects, it's a matter of asking, is there an anxiety or depression that's at play? We know those are very frequent with people with dementia. Is that something we need to treat? Is that something we need to fix? Ultimately, and I'm sure Sarah and Kelly can also have input on this, but we typically will not argue with people you cannot argue with someone with dementia because they will continue believing it. And there's no logic anymore. That part of their brain is not quite there anymore. It's not their fault. So we tend to go along with whatever they end up saying as long as it's not harmful to them. So if he thinks that there is a problem, then we say, okay, what's the problem? And they think this, and then we go outside and we say, oh, nope, it seems like everything's okay. We'll come back inside. So those things we typically will not argue, and we'll just confirm that they feel safe. And that typically will help improve it. And Kelly, I don't know if you had anything else you wanted to say about that while you're there.
As far as the dreams are concerned, no, I think you hit it right on the head. And when you were talking about, you are in the right place. First and foremost, let me just say that. So you're talking about strokes, but, and Dr. Bojarski can speak on this as well. There's so many people with what we call mixed dementia. So strokes are vascular, right? Blood vessels. So he most likely has been diagnosed with vascular dementia, although I don't know that 100%.
That sounds right, Kelly. Yeah. Mm-hmm.
There can be a lot more going on in the brain that we don't see. And right now we're doing lots of different research, as Dr. Bojo had said, in regards to Lewy body disease. There's a disease called late disease that older adults get, usually 80 and above, that we're looking at. So yeah, and we can talk a little bit more later in the day. And I'm not sure what the timing is, but there is one more question in the chat, if you can see that.
Let me see.
How do I handle when I believe it was mom asks for my dad, her spouse, who has been dead for quite some time?
Oh, okay. I see a question right before that as well.
Oh, okay.
I'll try and answer both. I'll try and answer both real quick. I see Aurelia said, what is the general timeline for late stage dementia and end of life, and how does choline and I'm assuming cholinesterase affect dementia? I saw this on a previous slide. So the general timeline for late stage dementia, we actually just worked on a presentation for this because it can be variable. It can be anywhere from 2 to 9 years from the time of diagnosis to the point of their passing. So it's very variable. It depends on whether you have a co-pathology, like Kelly had just said, whether you have vascular dementia and Lewy body, or, just one. Those can be very, very different. It's very different. When we evaluate you in the clinic, we are taking snapshots and data points so that over time we can give you a better understanding of prognosis. Now, in the later stages of dementia, it can be very rapid within 6 months. It can be a very rapid deterioration. And then how does choline and cholinesterase affect dementia? Like I had mentioned, it just increases the amount of acetylcholine in the brain. It helps the synapses work a little bit better, and it can help with day-to-day functioning of your memory. Not too much, but enough that it might make a difference. And then how can I help my mother when she talks about my father like he is there? He's been dead for 27 years. I told her one time that he had passed. I don't want to do that again. That's exactly what we were just talking about with the young lady who had the question here. It's something that you're not going to be able to logically help them address. They are in a stage of their long-term memory where they think that 20 years ago is today. And if that's not bothering anyone, let them think that. I know it might be really concerning from your standpoint, Teresa, for her to talk about him like he's there. But if that provides her comfort, if she's seeing him even and he's talking to her, I think that's kind of beautiful. I mean, that in this terrible end stage dementia, for her to have some sort of support and reassurance, I think that's really comforting for her. And so thinking about it from a comforting standpoint might be better to help you tolerate it, because it can be very disturbing. But understanding that when you take care of people who have dementia, you're needing to change and meet people where they're at. Things are not going to look the same as they once did. people are starting to regress back to as they were, say as if they were in kindergarten. So having those understandings is really important to help both you and your loved one have that quality of life, because that's really what we're aiming for here is quality of life, and treatment plans moving forward. Do we have time for more questions? I see that there's one more question. At what stage should we stop trying to use logic or discuss things? You'll know, because when you start to try and logically explain something and they don't understand, that's pretty much your understanding that they're at that point where their word finding difficulty might be playing a role, that they don't quite understand what you're trying to tell them anymore. They're not able to get their words out as well as they once did. I would say once you start finding that when you tell them something they don't understand, or when you try to use logic, they're not understanding, it seems like that might be a little bit more along those lines of the dementia's progressing, and it's time to maybe stop using logic and just saying, oh, well, we're going to do that later. But for right now, we're doing this puzzle. And that's that redirection that we talked about too. All of these are fantastic questions.
Thank you, Dr. Bojarski. We really appreciate that.
Sorry, I'm having trouble hearing you.
Thank you so much for presenting for us today. And thank you for answering the questions. We're going to take a quick break.
He's gonna.
Oh, sorry. Dr. Maddie's here as well. So he's wanting to introduce himself and go from there.
Hello, everyone. I'm Dr. Maddie with neurology. I'm the neurologist here at Highlands, okay? And so I have an outpatient clinic. I just wanted to introduce myself to everyone. Obviously, with the growing volume of patients in this region as well, I've been seeing a lot of patients in the clinic, just like she was saying, with mixed dementias and various types of dementias, Alzheimer's being one particular type. But I am happy to help. We're going to continue to grow and expand in the region. There are questions and patients that definitely need to come to the clinic. I'm happy to assist with that as well. We're just on the second floor up here, okay? I know you guys have had a workshop and a long day, but I just wanted to pop down in between my clinic today to introduce myself, because I feel like a face goes a long way. My background, obviously, I am still in the military as well. I'm a reservist in the United States Army. I teach as an assistant professor in neurology at Walter Reed on my time doing military obligations. And then I also go between inpatient and outpatient neurology, where we do acute stroke care as well. Anything you can imagine with neurology on the inpatient side. And then the clinic is a general neurology clinic. So it is bread and butter for all disciplines within neurology, with cognitive disorders being one, but also other things, seizures and stroke follow-up, and neuropathy and peripheral issues with like carpal tunnel. And we do a little bit of everything, headache management, multiple sclerosis. So it's kind of a one-stop shop, and we get things going and get the patients the care they need, trying to keep everybody local as much as possible, because I know it's difficult to travel, okay? Anyway, I just wanted to introduce myself. Does anyone have any particular questions for me?
I do know a couple of you mentioned when you came in that you had trouble finding neurology or had lost a neurologist. So Mary or myself, if you need follow-up appointment, Dr. Maddie works here, and we have two nurse practitioners that work with him, one virtual. So if your loved one has trouble getting out of home, and do virtual appointments, they just kind of zoom in like Dr. Bojarski did. And then we also have on-site clinic here. So, Mary's going to talk to you more about it, but she's our new navigator. So a lot of the finding resources, helping make appointments, those sorts of things are kind of Mary's sole job with Alzheimer's and dementia. So feel free to talk to us as we take breaks or after we're finished. But we did want you to meet Dr. Maddie.
Here I am.
And, so.
Happy to help everyone, okay? Yes, our team is growing and expanding, okay, to accommodate the needs. The virtual aspect is very nice for some of my patients who physically just cannot come to the clinic, but still need to have eyes laid on them from a neurology standpoint. And those nurse practitioners that see as well, if they feel like it's absolutely something that needs to come to the clinic, they will arrange that as well with me too. So we try to, meet all the demands that everybody has, both virtually and on-site in the clinic as well, partnering with all of our therapists for particular therapies too that patients may need, and obviously getting them the medications and assistance that might be needed as well. But it's a pleasure meeting everybody here today, and obviously I am available, so maybe I'll see one of you at some point in the clinic if you need further guidance and assistance. But happy to be a part of this and help out, okay?
Thank you.
Thank you. Now, listen, I do have a question. I'm sorry.
Always one, okay.
I want to absorb everything because I'm having a rough time. She's having a rough time. I mean, I've got tons of patients. But, okay, it's very hard to get her to even go to her primary doctor. And so we go once every 3 months to her. But she is in this later stage. Do I need to set up an appointment because the other neurologist she did not like him at all. And she let him know it, and she let us know.
See, that tends to happen.
Yeah, I mean, she walks, she don't sleep. She tries to, we had to put chains on the door. I mean, we had to childproof really my house. I'm back like a toddler, and stuff. Are they stuff that, maybe that you could help us with that she could still benefit from at this later stage?
Yeah, and I think, it would depend on the situation, on the type of dementia, the
She
type
got
of
vascular.
Okay, vascular dementia. Okay, so very stepwise dementia, we call that. But so it depends. We'd have to see her. But this would be an excellent case where you have a patient who has been extremely difficult getting out of the house to meet appointments, or a simple virtual may be helpful. And even though the patient may not necessarily want to participate in that, with a caregiver or a loved one that's there, having an interface on either an iPad or a phone, we would still be able to get a better assessment, even if the patient's not in the clinic, to see what needs we may be able to assist with, whether that's fine-tuning a medication regimen or ensuring there's nothing else going on that's making the patient have worsening symptoms. Sometimes simple things, for example, that would cause exacerbations with dementia patients, all dementias, would be infections, right? So subtle things like a UTI that most patients with memory difficulty will not say, oh, my bladder hurts, or, oh, I'm having pain here. And so that's usually one of the first things I go to when patients are having abrupt changes pretty quickly with behavioral and an underlying dementia, because they have this cerebral reserve, which is their baseline thought process and their cognitive function. And any infection will make that 10 times worse. It doesn't mean that the cognitive disorder is worse. It's just exacerbating the underlying features that have already been damaged because of the infection. So we usually like to make sure there's things like that that are not at play. But in a patient, getting back to your initial question, she may be someone who would benefit from a virtual evaluation if you're unable to successfully get the patient to come to the clinic. And then obviously safety is the most important thing. And it sounds like you're doing all of those things to make sure.
Oh, yeah. Well, I try to get her out. Well, at least I know if I get her out in the car and take her for a ride, she'll say where we're going. And I'm just out. We just go out driving. Because I don't like for her to stay in the house all the time and just walk. Right. Because that's not what she needs.
The isolation, it's good to change the environment up, particularly with seasonal changes too, with good weather outside. It's very healthy. Same thing with music therapy, relaxation techniques. These are all things. And obviously when patients are agitated, combative, trying to change and deviate that conversation is important, right? But not getting argumentative yourself because that will escalate it. But, many times I advise a lot of families, like, if it's vanilla ice cream and they're determined it's chocolate, okay, it's chocolate at that moment. We're not going to go with it's vanilla at this time. And 9 times out of 10 minutes later, completely different conversation, right? Yeah. Rather than feeding into that to cause that disruptive and argumentative issues, right?
We don't have a conversation.
Yeah, I understand that.
She says a word and then it's like jabber and then it's another word. And I just go along, or I'll, well, when did that happen? Well, I didn't know nothing about that. And I said, Lord, forgive me, but I like the woman.
I think you're doing what you're supposed to be doing.
All day long,
You're doing the right things, taking her out, changing the environment, changing the scenery. safety in place, protection mechanisms. I just always use cautious if someone has an abrupt change, make sure there isn't an underlying infectious problem. And if you can't get them to go to the appointments, I think that's where a virtual platform would be helpful.
Yes, well, we do that sometimes with Dr. Collins. It's like you never get there on time, and they know it now. You know, you never can get her ready. I don't care what it is. You know, you cannot get to an appointment on time. And I'm a person that hates to be late, but we're usually late.
Listen, we as physicians and any of the providers, obviously, I think we anticipate there's going to be delays with cognitive patients because of that. And we understand that. So we typically try to build schedules around that as well to accommodate. Okay. Good question. Anything else I can answer for anyone?
Thank you so much.
Pleasure, everyone. I'll let you, you're going to get back into that.
Thank you, yeah. Great questions.
Everyone, we're going to start. We have a packed schedule today, as you guys can see from the agenda. My name is Erin Gillespie, and I'm the Director of Programs for the Alzheimer's Association. And what that means is really the care and support pillar of our organization. So we work with community partners like ARH and UK Sanders Brown to bring you the latest information, how to communicate, also ways that you can best navigate as caregivers, but also bringing you resources to your fingertips. We have support groups, education programs specific to behaviors. I know we've been talking about that today. Also communication strategies, which Mary will be covering today. She'll go over some resources at the end of this presentation, but always know that you're not in this alone and that we're here to help support you. We also have a 24/7 helpline that I will give you guys some pamphlets. So that's really for anything, whether you need a power of just need someone to talk to. Caregiving isn't 9 to 5. We do know that. So we're always here for you 24/7. So now I am going to introduce Mary Crum. She was introduced earlier today, but not only is she a nurse navigator, but she's also an Alzheimer's Association community educator. So she does all the things. And so I'm going to send it over to her.
I just wanted to say thank you guys for coming. We're really excited to bring, all the resources and information to our area. Dementia and Alzheimer's is kind of dear to my heart. I started healthcare right out of high school and worked at the nursing home. And Gertie back there, she was my work mama and taught me a lot of things. And, so you build that compassion for those people, especially ones that, need our help. And then also caregivers, like Erin said, you're not alone. It can be very stressful. It's not a 9 to 5 job. It's 24/7. So we're here to help you. We're just going to cover a few communication strategies. Okay. By the end of the presentation, you'll be able to explain the communication changes that take place throughout the course of the disease. You'll be able to learn verbal and behavioral messages delivered by someone living with dementia. And you'll also be able to identify strategies to connect and communicate at each stage of the disease. So what is communication? Communication is pretty much everything: body language, listening, words, facial expressions. It's not really just the way that you talk to somebody. It's the way you present yourself. See if we can move this. Okay. So, as we talked about before, you have the early stage, middle stage, and late stage. Maybe in the early stage, it's not as, you don't have that as many problems with communicating as you may in the moderate stage. So once it progresses, you want to use basic words. You want to, once you get in that late stage, you want to know their familiar words. Maybe it's just a short word. Maybe they want something to drink, but they're going to say cup instead of I need a glass of water. So, and you also want to use your body language and also the 5 senses, taste, smell, all that good stuff to communicate. Changes you may notice is, they have difficulty finding the right word. which I do that now. So taking longer to speak or respond, you may ask them a question. It takes a little bit for them to respond because, you know, they're trying to gather out what they really want to say. And withdrawing from conversation. We went to a presentation with Dr. Bojo, and that's one of the things is social isolation. They pull back because of the embarrassment, or, you know, they don't want people to think about them because they can't say the right words. To connect at the early stage, you want to ask directly how to help with communication. You know, you want to keep the sentences clear and straightforward. You don't want to tell them a big long paragraph when you're just asking a simple question. And leave plenty of time for conversations. The key is patience. You want to have patience with them. You don't want to rush them. Avoid making assumptions. You want to speak directly to them. Laugh together. Be honest and stay connected with each other. The middle stages, it gets a little harder. You want to, you know, they may have difficulty finding the right word, but it's a little more than it was at the beginning. So maybe they use those familiar words over and over. I don't know if you guys are familiar with TikTok. I follow a lot of those patients that's living with dementia on there, and there's a little lady that says heavy, 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 and that's her word for describing everything of the day. So it was hard for her family. It's easy for them to lose the train of thought. So you may be talking about one thing and then they're jumping to another subject. So, and they want to communicate maybe through behavior rather than words. To connect with the middle stage person that's living with dementia, you want to approach them from the front and identify yourself. Even if they don't know who you are, you want to identify yourself. Maintain eye contact and get eye level. If they're sitting down, sit down with them. One of the biggest things is you don't want to stand over top of somebody and talk to them. They, you know, especially if they don't know you. And then pay attention to your tone. That's a real big thing. Even if you're losing patience with them or something like that, you still want to have that calm voice and make them feel safe. The same thing as earlier with the middle stage, you want to assess the person's needs. You always want to treat the person with respect and dignity. Let them know that you hear what they're saying and provide brief answers to them. For example, in healthcare, you know, when they come into the ER and you're trying to describe what's going on, you want to keep, you know, simple words so that they understand. And then also respond to their emotions behind the statement. Again, use short sentences, basic words, speak slowly and clearly, and then do one-on-one conversations as much as possible. If you have a room full of people and you're trying to talk to them, they're hearing all the conversations, trying to know what's going on, things like that. So, and again, be patient and limit distraction. You want to avoid sudden movements. Write things down for the person. Say, you know, they need to brush their teeth or something like that. You guys have a routine. Write that down for them and they have that as a reminder. Always be positive and never quiz them. Say, do you remember? That's one of the things. They get very aggressive about that and defensive about that. So be mindful of that. And then join the person's reality. In nursing school, we were always taught to reorient. That's not the case. You don't want to reorient. You want to be where they're at, or certain behaviors can come out if you keep reorienting. So just be mindful of that and, you know, kind of exactly what it says, just be there where they're at and meet them. Focus on their feelings and not the facts. And then late stages, communication gets really hard in the late stages. So you may notice that they only say a few words or sounds, maybe no words at all. A lot of people communicate with sounds. So to connect, you want to listen for expressions of pain or respond promptly and help that person feel safe and happy, because just imagine not being able to express how you're feeling and then somebody's just coming in and turning and changing you. You always want to explain to them what you're doing and let them know that, you know, you're just there to help them. And then keep talking to them. Even if they can't talk back to you, keep having that conversation with them. It kind of goes back to the, you know, using your senses. Feel different fabrics, identify shapes by touch, give lotion, hand massages. I don't know how much Gertie can tell you. They love their back rub. That if they're agitated for the day, maybe just rub their back a little bit. Maybe, you know, their back's hurting or something like that. You, but always you want to maybe hold their hand, stroke their arm, just let them know that they're safe. Through sight, you can watch videos of animals or nature. Maybe they like animals. My mom's a big squirrel watcher, birds, all that things. So, you know, maybe they like paintings or aquariums is really big. They love fish and all those bright colors. So, or go outdoors. Gertie can tell you, we used to sit on the front porch with them. They love that, the fresh air. Sorry, Gertie.
All right.
Connect with sound. Maybe it's music that they like. Maybe they played guitar when they were younger or something like that. So you can connect with them that way. Maybe it was a librarian. Maybe they love books. Maybe, you know, get their favorite book and read it to them. Even if they can't talk back to you, maybe they'll show a way that they're enjoying that. Smells. So in the late stages, it says, you know, you can connect with them through smell. So herbs and spices. Maybe they had a garden when they were younger, and that's all they think about is that garden. So maybe you can bring some herbs and spices, things like that for them to smell. Grass clippings. I love to smell grass, fresh cut grass. So maybe that's something that you can do. Coffee. And then use, you know, different scented lotions. Maybe they like that. They say lavender helps you relax. Maybe, you know, some lavender lotion or something. Through taste. Who doesn't love home-cooked goodies? Some popsicles, maybe some ice cream or pudding. You know, those little snacks, maybe that will help them communicate with you. Sit down and have a bowl of ice cream together. And then all stages, you know, you want to join that person in reality. So if they're waking up, like you mentioned earlier, your husband wakes up from those dreams. If he's safe, be in that dream with him as much as possible. Then understand and accept what you can and cannot change. That's one of the things about arguing with them or trying to reorient them. You're not going to change that. That's what they see, what they feel, that's reality to them. So just kind of bring present at that stage with them. And again, be respectful, patient, and kind. They're just as scared or agitated at times as we are if we get overwhelmed. So they just don't always know how to express that, and sometimes that becomes a behavior. So like Erin mentioned earlier, there's a 24/7 helpline with Alzheimer's Association. It's a free service. Somebody's there every day to answer for you. Whether you're just overwhelmed through the night and you need somebody to talk to, or maybe you need some resources, like you were asking earlier about was it your sister? Your sister, how to keep her calm, things like that. Maybe they can help you with different strategies that's helped with somebody else, maybe it'll help with her. You have that available. And on Alzheimer's Association website, there are all kinds of educational programs. There's some of them mentioned there before or on the screen. And then she also brought some handouts that you guys are welcome to as well. Online, there's this handy little website that you can go to, and it brings up everything under the sun. You just put in, I think you can actually put in your zip code.
Everything's located by zip code, so
Right.
community resources, diagnostic centers, support groups, whatever that you need.
So that pulls up everything. It's awesome to have. I was writing it down.
It's also crf.org too, that alc.org/crf. It's a little easier than that huge.
And then again, you can find free online communities and caregiver resources on the website as well. I'm not really familiar with this resource, so I haven't.
Oh yeah, so our ALS Navigator, they just now redid it, which is a great resource. Say, for instance, you're having difficulties with, I don't know if my loved one should drive anymore. That's a common question we get quite often. And so what the ALS Navigator does is you answer questions that are relevant to your situation, and then it prints out a individualized action plan specific to your needs. So all this is online, from driving to caregiving, legal planning. We always talking about start planning now so that your loved one can be part of those conversations. And so some people don't know where to start. It's a hard process. There's a lot of boxes to check. So you can go on this ALS Navigator. You can also call the 1-800 number. That is our organization, not contracted out. I always like to say that because it is a 1-800 number, and all of this, these days it's kind of like, do I call that number? How many numbers am I going to push? Who am I going to talk to? But it is our organization, and is master level clinicians can also give you a care consultation for free. But the ALS Navigator, it's great. It's very individualized. And so again, you just type in your it'll give you an individualized action plan.
Any questions about communication or anything else?
I do have a question about driving.
Okay.
What's a good way of starting that? Well, we started that conversation.
So I'm going to do a safety conversation, or I'm going to present on safety, and I have a whole big section about driving, and then I can talk to you afterwards as well. Because there's kind of a step list of things as far as noticing there's a problem, getting help, and then obviously
I'm sure all those boxes are checked.
Okay.
It's just talking to or convincing a very strong-willed.
So a person with the disease can't be convinced, right? So it's really you can't bring them out of their reality, and you both are going to go crazy if you try. What we talk about, and what I'll talk about in the safety conversation, is compassionate deception. So that is something to keep you all both safe. And we can talk about some other ways, taking a car battery out. If it's an actual key ignition, unfortunately, they don't have a lot of those anymore, but filing that key down so it doesn't work anymore and giving them a different key, so that they think they still have their car keys, but they just don't know why. And feign ignorance. I just don't know why that car's not starting. I'm not really sure either, meanwhile, you put an old dead battery in there.
She said,
Okay, well, we can talk more after, okay?
You're talking about snacks. My sister would rather have junk food than anything else. How much snacks do I give her?
That's what she wants, dessert first. Once you get an Alzheimer's diagnosis, that's what I say, dessert first. But honestly,
Do I let her eat as much as she wants to eat? And drink?
obviously you don't want her to get diabetic, and that's something
She's already diabetic.
have a conversation with her. The reason why we love that salted stuff is our taste buds get a little bit more than your
when we have Alzheimer's disease or just as we get older, but also our brain runs on glucose. And so because it's a brain disease, it's constantly trying to get that hit, if you will, which is why if somebody's in a bad mood, give them a bowl of ice cream and watch that mood disappear. Give them a Snickers, give them a cupcake. And it's really,
But I just want to.
well, I would talk to a dietitian about that specifically, but honestly, particularly if you're having if they're very agitated, if you're in if she's on her walker and she's been on her walker for 8 straight hours and you've not been able to get her to sit down, honey, put a bowl of ice cream in front of her and have her take a seat. You know what I'm saying?
She'll eat that bowl. Okay.
I believe me. That's okay. At least she got a few seconds down.
You know.
Yeah.
But I mean, she walks 12, 14 hours a day. I mean, from room to room, nothing else. And you keep the bathroom doors shut, you keep gates up between the utility room. I have a hard time with her around the stove. How do I do that to keep her when you're cooking, to keep her from the stove?
Bill's gonna cover that.
Okay. I'm sorry.
Those are great.
Question. I mean, I've got tons of them. I am so sorry, everybody.
I love people to ask questions. I guarantee you there's at least 2 people online and at least 1 more person in here that has the same question. So do not apologize.
Well, I just want to take care of her the best of my ability. She's 9 years older than I am. She carries me around. She was, I was her little baby doll because I was the last child and I was the baby.
Yeah.
And I'm not going to see her go in a nursing home. As long as the Lord gives me strength and the patience, I'm taking care of this woman.
Well, you're taking the right steps of being here and learning more.
That's what
part of
Yeah,
absolutely.
And she hangs to me. I mean,
Is somebody speaking on resource? Mary, are you doing resources?
Agency on Aging.
Okay.
Mary will talk about our ARH
Okay, so is it me? Yeah. All right.
I'm sorry about this.
No, don't be sorry. That's what we're here for.
No, but all these other people don't want to.
Well, they're not going through it right now. They may in the future. So all information is good information.
I might just sit in here. Okay, so I'm always a little nervous when I speak. I'm afraid that I might forget something. So pardon me if you see me glance down at my notes. All right, so I'm Kelly Parsons. I work at Sanders Brown Center on Aging. We do a lot of Alzheimer's research. We also do other dementias, as Dr. Bojarski was talking about. We have a clinical trial going on right now for a study it's a disease called late. We also are building houses, Dr. Jaika's memory care clinic through UK Healthcare as well. I've been in the field for, I guess about 25 years now. I started in a skilled nursing facility in West Roxbury, Massachusetts, where my husband was stationed up there. So originally from Lexington. And it's so great to be here. Just a huge shout out to Mary and Rachel for making this possible. I think that this is a great program and we're excited to have more like this. Okay, all that's out of the way. So I'm going to start by reviewing some definitions and then move into how we can clinically assess for memory and thinking problems and how that relates to safety. But just so I can get an idea of who's here. So if you think of Alzheimer's within 3 stages, right? Early stage, middle stage, and late stage. And late stage is really kind of sounds like what your sister's going through right now. So yes. Raise your hands. How many people have a loved one with an early stage who might be in the early stages of this disease? Great. And what about somebody in the middle stages who have loved ones? Awesome. Okay. And then late stages? All right. Okay. Well, thank you all for being here so much. Let's get this going. Oh. I don't know what that means. Yeah, let me just,
I have my husband, sometimes I look at it and I think it's middle stages, but then other things, he's got some of the same symptoms for late stage.
Yeah, and there's that line too in between middle and late. That we just, it's
kind of like they go back at like crossover. There will be
I
some
mean, you can do
crossover.
certain things and then,
right.
but there's a lot.
And we'll talk about too, I can just kind of hit on, that was such a great point. He can do certain things. So we have what's called sundowning with Alzheimer's disease. And it really is towards that end of the day, they've used all their energy and expired all of their brain power really to function during that day. So by evening comes, their circadian rhythm is a little bit messed up. So as far as like night and day, their internal body doesn't really know how to process that. So you might start seeing a lot of agitation as the sun goes down, maybe a lot of anxiety and pacing behaviors, things like that. I love summertime. It is so fantastic as far as everybody's mood. Everybody's getting vitamin D, but also there's something about being up and active. I will say if your loved one falls very, very quickly into behavior you've never seen or becomes incredibly agitated or almost has like a delirium to them where their dementia is different in a way that you've not seen, please get them checked for a UTI. It's summertime and it's hot, and people with Alzheimer's disease, if you've worked with any of them, you know they can go down really, really quickly and have a lot of terrible behaviors to try to address. So that's just my 2 cents. Okay. So I know Dr. Bojo went over this. I'm not going to talk about it very much, but I just wanted to kind of review these definitions. Also, you're going to get a video of this. It is being recorded, I think it is. And then emails of the slides as well. So really cognition, when we talk about cognition, it's the ability to think. It's the ability to think and process. And Dr. Bojarski talked about mild cognitive impairment. And the reason I talk about it is because Leqembi is available for mild cognitive impairment. And all the research shows the earlier we can address this problem, the better, the more quality of life, the longer independence you or your loved one will have. So mild cognitive impairment is a medical diagnosis. This is the in-between stages of typical or normal thinking skills and dementia. This condition causes memory loss, trouble with language and judgment, but does not affect daily activities. People with mild cognitive impairment, also known as MCI, if you've heard that being said, may be aware that their memory or mental ability has changed, but also some of them might not know. If they're not sure, if they don't know that they have a memory problem, it's called there's a medical term for it. So when you say like, oh, he says he doesn't have a problem, but he really does, he really might believe that he doesn't have a problem. That's not him trying to put one over on anybody or anything like that. That is an actual medical condition. So for MCI, these changes aren't bad enough to impact daily life or affect usual activities, but it can show up as people needing longer to process. So process what they might be saying. They make more lists, use their phone more for reminders. But overall, a person can continue to live throughout the day as normal. MCI raises the risk of developing dementia caused by Alzheimer's disease or other brain conditions like vascular dementia. But for some people with an MCI diagnosis, symptoms might never get worse. They might stay the same, or they might improve if it's a vascular issue and all of a sudden they've tackled their blood pressure or their diabetes, things like that. Okay, so dementia, and I know that Dr. Bojo talked about this, but dementia is the umbrella term for all of the other very specific types. So we're in Kentucky, not all whiskey is bourbon, but all bourbon is whiskey, if you want to think about it like that. As far as not all dementia is Alzheimer's, but all Alzheimer's is dementia. It is a medical condition. And it can include memory loss, confusion, problems with speech, paranoia, changes in mood and behavior. So this is really important. If you have a loved one that has been diagnosed in memory medication, and Dr. Bojarski talked about those, so it's the donepezil or generic Aricept. They also have a patch called rivastigmine, and then it's the memantine, which is the generic for Namenda. If you see any of those medication bottles in your loved one's home, and the first thing you need to ask is what type of dementia is it? Because that's really going to help the medical providers care for any behavioral issues, and also help decide if maybe things like Leqembi or other forms of treatment are good for you. Okay. So Dr. Bojo talked about this, but also please advocate for memory and thinking tests for your loved ones if you are looking at it. There are lots of tests that will rate your brain thinking ability. The most two common is the MoCA. The ones with the animals is called the MoCA, the Montreal Cognitive Assessment, and then the other one is called the MMSE. And these should be done regularly for someone who has a medical symptom of dementia, because based on these scores, and you'll see, we'll get into it, but based on these scores, there are parameters in place regarding safety and decision-making capacities. So really, what does that mean? Well, what can an MMSE tell us? So this right here is from the Academy of Neurology, and it is a driving parameter. And so the mini mental status exam is 0 through 30. We would all score 30 if we took the test right now, maybe a 29, depending on how much sleep we got. But what the actuaries got together, so a bunch of insurance people looked at cognitive test scores like the MMSE and said that if you have a 24 or less, you're uninsurable. You're not safe to drive. So we want to, and one of the reasons this is so important is for safety, but also if your loved one has a diagnosis of a dementia in their medical record and they get in a car wreck, insurance companies can subpoena medical records. And if that's the case, even if it wasn't their fault, they might be on the hook for all of it. So just, we have had that happen before. I'm not saying it happens all the time, but there are lots of different reasons, safety, of course, being number one to think about these things. Let's see. So what can they tell us? And I won't talk long about here, and I'll kind of get up and talk about it. And Dr. Bojo put up the slide as well, and I think it's just so great. But because it's not cancer, right, we don't lose our head, so we don't automatically look at somebody and remember, oh gosh, they're fighting this terrible disease, or there's not an arm in a cast or on crutches where we can automatically attune to this person needs a little bit more assistance. It's in our brain, so we can't see it unless it's imaged. But truly, if as you decline in and many mental status exam scores, you decline in the ability to function with your activities of daily living, like dressing, maintaining hobbies, disposing of litter. Sometimes I had a lady at the day facility that I worked at, and she had tissues just all down here at the end of the day. Yeah. Folded.
Every
clean.
Everything.
Yeah.
Yes.
Yeah. And that's
I have to
just
shake everything before I walk into the closet. If not, then I have to shake.
right. And part of that is just kind of the generation at hand, but also part of that is they don't know where to put it. It's that initial step. And I talk about this when I'm talking to people kind of in that moderate stage with their loved ones. When we talk about making a peanut butter jelly sandwich, it takes us about 3 seconds about what we need. But if you really think about it, you have to get the peanut butter, you have to get the jelly out of the fridge, you have to get the knife out of the drawer. Where's the bread? Is it in the bread box? Is it in the freezer? Do I need to thaw some out? Okay, now how am I going to do this? Where's the plate? So there's a list of things that we have to go through that's just inherent to us because we've been making peanut butter and jelly sandwiches since we were probably 6 years old. But somebody with a memory and thinking disease does not have that wherewithal to think about what's next on the list. They might be able to hold 2 to 3 things at most. So when we ask, like, do you need a list, like a to-do list, that inner monologue of like, I'm going to go and load the dishwasher as soon as this commercial is over. And then the commercial starts and we know to get up and go do that. That inner monologue of what comes next within our day, even within our month, right? Like I got to pay my car bill or my car taxes in September, but just all of those activities of daily living come much, much harder for people with this disease. Okay, I'll get off my soapbox there. All right. So what we've come to talk about, how does this relate to safety? So Alzheimer's disease causes a number of changes in the brain and body that may affect safety. Depending on the stage of the disease, this can include judgment, so forgetting how to use a household appliance like a microwave or a stove, sense of time and place, getting lost on one's own street, physical abilities, having trouble with vision, having trouble with balance can be an issue due to Alzheimer's disease. And then senses, right? So experiencing changes in vision, hearing, depth perception, and then behavior. So becoming easily confused, suspicious, or fearful, lots of anxiety or agitation as well. So judgment and decision-making. So this is for both simple and complicated choices, right? So you might get a package delivered on your door that isn't yours, but is your neighbor's down the road, right? It takes judgment and decision-making to say, that package isn't mine, I didn't order it. Oh, it's Bob's down the street, I'll just go take it to him. Or I'll just leave a note to the mail delivery person, wrong house, right? Fixing those problems is judgment and decision-making with somebody with Alzheimer's disease has a harder time to do. Navigating social interactions, right? So when should I speak? How engaged should I be? Things like that can be difficult and is in the realm of judgment and decision-making. And then risks and benefits for medical treatments. So some of the things that I want to highlight in regards to Alzheimer's disease and judgment and decision-making is monitoring finances. If your loved one has the capacity to do a power of attorney, a durable power of attorney, and we can talk about that if you all have specific questions, I think that's really important. If you're further down the road with the disease and that's not possible, trying to get on the bank accounts, limiting the amount of cash, using a prepaid debit card is always a really good idea to try to keep, because we also want to give people their independence and autonomy. There is dignity in risk. There is dignity in the decisions that they can make and have the wherewithal to make at a certain point within the disease, of course. Firearms, try to keep them locked, try to keep the bullets away from the actual, or the ammunition away from the guns. I know it's really hard. It's easier to take somebody's license away than it is their gun. So just try to make sure everybody's safe in the home. You might want to ask for local law enforcement for help. And then in the garage, if you've got somebody that really loves woodworking and has lots of saws, things like that, you really want to be aware of. Try to get some built-in protection of those or make sure they are supervised when they're using them. Medications. So I think we all have different ways of taking medication. Some people keep it in the pills, some people put it in the box. We'll talk about ways to make it a little bit safer later on in the conversation. But if you go to, grandma's house and you see a pill bottle still full from December, chances are they're not taking their medication appropriately. Do some digging, talk to the pharmacist, see when the last time they had a refill, see if they're calling too early for the refills or getting them much too late than what they should. There are some medications, particularly like heart medications, that can be very dangerous if you take too much of them. We had a person, they had a pill box lined all out. They kept forgetting that they took it. And by the end of the day, all the pills were gone out of the pill box. And an ED visit was shortly thereafter. So just be mindful about that. And we can talk about kind of ways to help with medications. All right. So I would be remiss if I didn't talk about safety and scams. I think there's a special place down under for people that do this, but that's another story. Have conversations often and monitor financial accounts. Speak with their banking institutions to see if they are able to put any safeguards into place. I know my mother froze her credit, so no one can get a credit card in her name, not even her. She would have to unfreeze it. But the banking institutions do have some safeguards if you want to talk to them about it. Using a PO box, we had a lady, oh gosh, she gave a lot of money to those mail-in scams. So using a PO box instead of a home address might help. getting access to their email accounts, because there's email scams. There's internet-based call blocking services through your phone provider. If you have a landline, I suggest turning off the ringer, which means if your loved one can still call for help, if there's an emergency, they can still do that, but they just don't get all the phone calls coming in. Apps on smartphones can include call control and Truecaller. And then you want to talk about the tactics scammers use. So scammers pretend they're from an organization that somebody might be familiar with. Like the Kidney Foundation is near and dear to my heart, so they might say that they're from the Kidney Foundation. They can change the call coming through. And if a person answers the phone, that's what they call a live number, and they actually can sell that number to other scammers. So even just by answering the phone, you can give these people money sometimes. They'll tell you there's a prize or a problem, and there will be absolute urgency. They don't want you to hang up. They'll require payment in a very specific way, like gift cards or MoneyGrams, things like that. And these are just conversations to have in general with people you know. We had our nurse practitioner get scammed. They said there was a problem with her Amazon account, and the hackers got direct access into her computer. It's all magic to me. I'm not quite sure how they did that, but all of a sudden there was a scammer in her Amazon account making purchases. So just FYI. Okay. Whoops. Oh, so I'm sorry. There's a whole note there. Okay, I got graphic. I try to be fancy and get graphics, and then I forget. Let me make sure. Okay. So sense of time and place. So wandering, pacing, things like this, any signs of that or being unaware of their surrounding is cause for concern. Look to medical providers and social workers for assistance and referrals. Alzheimer's disease is a progressive neurodegenerative disease, and due to this progression, most persons diagnosed will become unfamiliar with their surroundings to some degree, some more than others. I always say if you know a person with Alzheimer's, you know one person. While behaviors there's groups of behaviors and there's groups of things that are in common, it's still an individual diagnosis. So when noticing a decline in concentration or orientation, it's important to observe your loved one's abilities and modify routines as needed. For example, if they continue to ask, what are we doing today? What's going on today? Where are we going? What's happening? Who am I going to see? Why are we getting dressed? Having a big whiteboard, either in the kitchen, the bedroom, the living room, that says what the day is. It's Wednesday, it's Tuesday, actually. Yeah, it's Tuesday, sorry. It's Tuesday, June 24th. We're given a talk about safety at ARH, right? Having a calendar, a big calendar to keep track, like, if they've got loved ones coming, your brother Daryl's coming to visit on this day on the calendar, because it's interesting what people can grab onto and keep and remember and then ask about over and over and over again. And they're not asking to be rude. They're just asking because they really do not have the ability to keep short-term memories and don't know what's happening. If they can still read, writing it down and asking them to refer to that, or, oh, it's in the kitchen, it's on the kitchen table, why don't you go see what we're doing today, just to give you a little bit of a space or a break. Telling people what's happening next. So Dr. Bojo talked about routine. We are routine creatures just in general. We're creatures of habit. So somebody might be worried that they don't know when their meal is going to come and they're hungry, but they don't have the words to say that. So telling your loved one, it's about lunchtime, or we're going to eat about 20 minutes. We're going to eat in about 5 minutes, and start getting them from the living room or their bedroom to the kitchen table, or start setting up their TV tray so they kind of initiate what's happening. Is really, really helpful in regards to making sure they're on board for what's coming next, right? When you give medication to somebody who has dementia and then a fight ensues, just remember you're the one that came and bothered them. I like to say that. It takes two to tango. It's always okay to step away, to take a breath, to take a moment. It can be incredibly frustrating and difficult to deal with some of the connotations that come with this disease. Using labels or pictures. I had a lady that in the bathroom, she put her husband's morning routine. So you brush your teeth, you shave, and it was just on a piece of paper in the bathroom, and he was able to look at that and go from there, which is really, really helpful. Placing pictures or labels of where the cabinets are, right? The cups are in this cabinet, the plates are in this cabinet, so they can still unload the dishwasher and help and feel useful. And, you know, it's in our human nature to want to feel useful. So anything that you can allow your loved one to do on their own is really, really great for them, and also stimulate their mind and keep those neurons connecting to each other. Using activated voice timers like an Echo or Alexa for medication reminders is also really great. And then reaching out to other caregivers, medical providers, and social workers and loved ones is crucial when addressing wandering behaviors. And we'll talk more about it. So, action items for safety: create engaging opportunities and activities. So for somebody in the moderate stages, maybe an easy Sudoku, and if that might get a little bit harder, maybe a word find. Maybe your loved one loved crossword puzzles, but that's getting a little bit difficult. So maybe move to like big print word finds or books on tape, just things like that to help. And then let's see, if you're in the later stages of the disease, kind of the end stages of the disease, sounds, so music. One thing that is really interesting with this disease, what is kept is music, psalms, and prayer. So we have people who are unable to eat anymore and can still vocalize songs that they sang when they were children. So pictures, even if they're not organized, if you have family pictures, putting them out, letting them go through, and then you can tell the stories, and they might not remember, but they can feel that love. They can see that love in the picture. They might not know that that's their grandfather or that's their grandson in the picture at his preschool graduation, but they can see the love in that picture. And we don't have to correct them or quiz them either. That can cause a lot of agitation as well. I like to use this example. My husband's grandmother, so my grandmother-in-law, I guess, passed away from this disease. Towards the end, it wasn't her house. Take me to my house. This isn't my house. I don't belong here. And the children went and got the mortgage out of the safety deposit box and showed it to her. And she said, "This is a fake piece of paper. You've made this up." So people with Alzheimer's disease will make their reality what it is to make it make sense in their head. And there is no type of showing them a mortgage, explaining to them you all been married for 50 years and you're not cheating. None of that will deter really what they're thinking. We really have to react to how they're feeling and not what they're saying, I think is a good way to break that down. So keeping them engaged in activities. So local libraries are a great place. Senior centers, I'm sure, any type of seminars or anything like that that's going on. The local playhouse, I don't know if they're doing it now since they're doing all that construction at Jenny Wiley, but the playhouse down the road, just different things that you can take them to get them out of the house and active. Because providing engaging opportunities and activities really will help some of that agitation, some of that anxiety, that pacing, that wondering, things like that. Let's see. Also, make sure your loved one isn't hungry or needs to go to the bathroom. And I say this, we had a gentleman, late stage dementia, started to get very, very aggressive, very aggressive. Took him to the ED multiple times, emergency department multiple times, couldn't figure out what was going on. His urethra was blocked, and he couldn't urinate, and his bladder almost burst. But because he was in the late stage dementia, he couldn't say, "I can't go to the bathroom." So just, when you see all of a sudden that abrupt agitation, again, something medically is going on, and talk to your doctor about it. All right. And thinking about safety, if you do have somebody that likes to wander, it sounds like your loved one doesn't wander, doesn't try to get out of the house. She just walks around the house.
She tries to open the door.
Okay. So
She tries, but, you know, like I said, we put chains at the top and, you know, like you have in a motel room, so if she gets it open, you know, and things.
Yeah.
I have a deadbolt, and she couldn't open the deadbolt for the longest time, but now
you give her
she can open that deadbolt.
Yeah. So another thing you might want to think about is the doorknobs that just spin, those safety cover for doorknobs. So you really have to kind of get a grip there to pull it. You can find them, I think, in the baby aisle. But due to safety hazards, just make sure you're there with her. So if there is a fire or anything like that, you can get out very, very quickly. Let's see, I'll talk about that a little bit more. But in promoting safety, yeah, that's the next. Okay. Make sure all my graphics are up there. All right, so driving concerns. This is the big one. This is, you know, it might not be so bad in other countries, but we are an automobile association. So if your loved one has trouble locating familiar places, trouble following directions to find new places, failing to observe traffic light signals, driving way too slow, or making poor decisions, if you see a popped tire and a bunch of dents, might be time to think about taking those keys away. Poor lane control, so not really knowing what lane to be in, and then becoming really, really angry. I've seen this before, just a very mild-mannered person, not a big deal driving with, and then all of a sudden everything is an affront to them. They're upset about the person next to them, the person in front of them, the person behind them. No one can do anything right. Things like that. And really what that's showing us is their personality is changing. And Alzheimer's disease affects personality. So you're going to see that come across in driving as well. So how do you approach driving concerns? So if your loved one is in the more moderate to early stage, having those conversations, hey, I'm really worried about your driving, and with this diagnosis being on your medical record, let's talk about some maybe safe alternatives, like limiting driving to just daytime, limiting driving to just the places in the neighborhood that you know how to go to, limiting driving to only when I can drive with you in the car, things like that. Have a conversation with the doctor. We always talk about we will be the bad guys. We are happy to be the bad guys. Dr. Jaika will sometimes write, do not drive on a prescription pad. So, and our caregivers will put it on the refrigerator. And so when they get really mad and heated, and I don't envy that, and I don't say that it's not hard, because I'm sure it is. I've never been there in that position, so I can't speak to it. But saying, Dr. Jaika said, just trying anything to try to get the heat off you, really your medical providers will help you do. And then plans for alternative driving. So how do I stop it? So, and I talked a little bit about this, disabling the car. So Fraser and Louisville and Cardinal Hill and Lexington offer driving safety tests. They do it, it's like a full 3-hour day. You do kind of like a driving simulator, and then you get out on the road, and then they'll tell you if you're safe enough to drive or not, or they will send a letter to the Kentucky Department of Transportation. That does have some monetary funds. It does cost something. Sometimes what we will tell our participants is if there's a National Family Caregiver Program that will give some money yearly to people. It's not asset-based, so they're not going to look at your house or your funds or anything like that. But that can be used as a driving evaluation. And we'll talk more about the National Family Caregiver Program. I won't forget about that. But that, as far as driving is concerned, is a good start. We say if you can tow the car, because the less they see it, the less they're reminded, oh, I'm not driving that anymore. Or, you know, have it at your son's house if he can keep it for a little while, just things like that. Just little things can go a long way. Oh, my fancy graphics. Okay. So physical abilities, really, I think if you're over the age of 60 and you break a hip and go to the hospital, you have about a 50% chance of mortality. Just hospital-based infection, not being able to move around anymore, things like that. So we definitely want people to stay physically well. And looking at fall risks, stairwells, if you could put handrails on both sides of the stair, that's amazing, but make sure it's well lit. Make sure there's not any clutter on it. I say that as I know there's clutter on my stairs at my house right now. I think there's like shoes and some shampoo bottles that need to go to the bathroom. But trying to make sure that things that people can slip over, like if furniture is in the way, any extension cords are on the floor, throw rugs, things like that. Having a light switch at the top and bottom of the stairs is really important. If you could put night lights in that are motion activated as well in your room, that would be really great too. If you have to get up at night in the middle of the bathroom, you're not blinded when you turn on the light, but as you're going to the bathroom, you can see where your feet are going. Shoes fitting properly. So what is it? Our nose and ears always grow, but everything else kind of shrinks. Our feet shrink when we get older. So our shoes might not fit. So be mindful of that. If you see somebody kind of walking out of their shoes, see if they're wearing the right size. And then if there's been a series of falls, don't hesitate for a home health referral. Home health can come in and do physical therapy to try to build some strength. You do have to see a medical provider to get a home health referral, but they can come in. Some home health agencies have occupational therapists that can do home safety evaluations. And at the end of the slide, there's a whole home safety check. And you'll get these slides at the end of the program. They're going to be emailed to you. So that is home. And let's talk about more of how to keep things safe. So adaptive equipment in the bathtub. I always say a well-placed grab bar is a hip saver. In the bathtub, place a nonstick mat or decals for traction. If you have a glass shower doors, if it's possible for you to take those glass off and then just put a rod up with a shower curtain, if you fall on a shower curtain, you're going to be a lot less hurt than if you fall on glass. So just some things to think about within the bathrooms. These are considered adaptive equipment, like the shower chair. I don't think Medicare pays for that. The raised seat's really great. I do think Medicare pays for that. And this is in your packet, but CARET is an organization. Are you familiar with CARET, Mary? Okay, yeah. So it's coordinating and assisting reuse of assistive technology. And they can help with walkers, shower chairs, hospital beds, hearing devices, lots of different things. So if you need some assistance within bathroom safety, they can assist. Right. So when I talked about Alzheimer's affecting every part of your ability to interpret the world, it affects all of our senses. So in regards to sight, there might not be anything physically wrong with your eyes of your loved one. However, the brain's ability to interpret images may decrease. This can cause confusion, disorientation, and the inability to recognize familiar people or places. I know that's a really big one too. So if you think about Alzheimer's disease, our short-term memory goes first, but we know where we were born, we know when we got married, we know what high school we went to, and that's considered long-term memory storage. And that really is one of the last things to go. So when your loved one when your grandmother might confuse you with her child instead of her son, they're really kind of reverting back. They expect people to look how they look 30, 40, 50 years ago. So when they look in a mirror and they say, I don't know who that person is, it's because time doesn't really exist for somebody with Alzheimer's disease. So they don't know the place and time ages them and their experiences. They've kind of reverted back to their 30s, 20s, things like that. Smell Look for spoiled food. Try to keep an eye on that. I know we had a lady who kept her ham in the cupboard. I think maybe that's what they did when she was a child, but it would just, her son was just constantly throwing out ham. I mean, you just go there and just throw out the ham. Taste. This can affect a way the person eats. There's danger and confusion, leading them to place hazardous items in their mouth. I have a slide that's not in here, but it's a hemorrhoid cream and a toothpaste tube, and they look the same. There's cleaning products that look like blue Gatorade, and then there's the blue Gatorade. So really make sure any type of toxins or poisons are away or not in their normal path. Don't have it by the sink or next to the toilet where they can easily get into it. Hearing, as in the case of eyes, a person could test as having perfect hearing but not be able to process sounds. This can lead to agitation, confusion, or overstimulation. So if you've taken your loved one, particularly in moderate, right, so they're still able to socially interact and behave socially expected behave, but they might get really, really overwhelmed if they're in a big group like this, or if, it's Christmas time and everybody's visiting family, or it's graduation time and there's a graduation party, because it's really hard to filter out that white noise that you and I can filter out so easily versus conversation. So if there's 4 people in a conversation, they're trying to follow and understand 4 different conversation topics. So if they seem a little agitated or if they seem a little socially withdrawn, kind of making sure that they're in a space that's a little bit quieter, maybe not as much people, they've had food, they've gone to the bathroom, or they know where the bathroom is just in case, might really help them interact with people at that function in a way they wouldn't be able to if they were right smack dab in the middle of it all. Because hearing those sounds and interpreting those sounds are really difficult for someone with this disease. All right. And then touch, as well as all the other senses, sensitivity to touch decreases. And it really kind of depends on how severe the Alzheimer's disease is, but people might not recognize hot or cold or being in pain. Like the gentleman who his urethra was blocked and his bladder almost exploded. Like he just didn't know he was in that much pain, but he knew it hurt, if that makes sense. So for hot water, if you want to put like a little red fingernail polish, and I'll get into it a little bit more, just to kind of alert, right? It's just that muscle memory, if you will. Oh, red means hot. Okay, this is the hot side, right? Especially if it's the sink that has the 2 coming in the middle, because they might not be able to feel that their hands are scalded. All right. So depth perception, eyesight, senses. We have a lot of people that say, I can't get my loved one in the bath anymore. I just can't get my loved one in the bath anymore. And if you'll notice in this picture, you've got the white toilet with a white lid, with a white background, and it just all kind of blends in together. Landon, somebody that doesn't have great depth perception because of this disease, and they don't know where to sit. So if they're having accidents, they know where the bathroom is, but they're having accidents. Getting a rug around the toilet, or putting those wallpaper, the kind of sticky wallpaper, you can put it on the back slide so that you can really get a definitive understanding of where the wall begins and the toilet ends, or where the bathtub ends and the toilet begins. It's those kind of like sticky mat things that you can use. We also encourage you, if you've got a white tile in the bathroom with a white tub, just throw some color on there so your loved one can understand where it is and what's happening. Sometimes even like understanding there's a step there, they won't get in the bathtub. Well, they don't know to lift their leg up because there's the rail right there. So really kind of some simple things that we can do to help people be more independent with this disease. And a couple of safety items that I want to talk about. I can't talk enough about automatic lights. I really think they're really great, particularly when it's dark out. You have somebody that loves tea. They're kind of in the moderate stages. They're still able to make it, but you're kind of worried or concerned about stove use. Electric kettles will be great. Ceramic heaters instead of propane. What is it? What's the other fuel called? it's propane and kerosene. Thank you. I couldn't think of it. I could smell it, but I couldn't think of it. That's always really good. These are door alarms. I know you said you had locks, but you can get them off Amazon. I found some at Dollar General. And it's just a little magnet. You put one on the door frame and one on the door, and when it moves it alerts you. So if you're worried about somebody walking downstairs at night and you don't have a gate up or a gate's not feasible to put up, door alarms are really great. They don't necessarily need to be at your front door. They can be in any doorway that you need.
I put a camera in the bedroom where he is because every time I hear a noise, I would go to see if he was getting up.
Yeah.
Because he wasn't stable. And so when there's movement,
Yeah.
I mean, I get it even when he rolls over, but when there's movement, they notify me on my cell phone and I can look to see if I need to go, if he's trying to get out of the bed or, if he's just rolled over. That has been incredible.
The technology. Yeah, we have people that do it in the kitchen. And they do it. We've got a gentleman now, again, he's kind of that moderate sliding into the severe stage. But his daughters look on the camera, and if he hasn't taken his meds, they get alert from their phone and they'll speak into the camera, "Dad, take your meds." And it's really, really helpful. So this is some of the stuff in regards to wondering as well and using the stove. You might want to go to the hardware store and get a big warning sign and put it on both sides of the stove. And so when she's there, she might see that, again, that muscle memory. Oh, when I see a red sign, I know to stop or I can't do that. It might help kind of, but also sidebar, you're her safety. When she sees you, she knows she's safe. We call it, Erin knows what I'm about to say, is shadows. They just kind of shadow right here. And it really is, they don't know what's next. They don't know what's happening, but they know, and they know, you're going to keep them safe.
I just want to keep her safe, but I am so afraid that when I step away, she's going to grab a pot.
Right.
Or something.
Yeah.
That's my biggest concern.
Can you put her in the living room with a bunch of pictures or anything? Or can you put her at the kitchen table? She has to be standing right next to you.
She follows me around, and I mean, wherever I'm at, because, and even if we're sitting chair to chair, and we watch a lot of Westerns, because that's what she used to watch all the time, was Westerns, So I leave the TV on that. No?
And I'll get to that. Let me do this first, but we'll talk about restaurants specifically. It's in my slide.
Well, and also when you're cooking, is there something else you can do, like wash the dishes or get the plates out and the silverware? Give her a different activity.
And she likes to fold. My mother likes to fold. We discussed.
She won't fold tables.
So I did with my grandmother sugar packets, like pink ones, yellow ones, white ones, and like we sort them out, like because that's very simple and it, they're color coded. Just say, can you make sure that these are like all the pinks are together and all the whites are together? And so giving her something else to do while you're cooking may be helpful, whatever that task is.
Also, so for Alzheimer's patients, particularly in the moderate stages, that depth perception is really off. It affects everything about us. And they look at black rugs or black spots as holes. They don't know that they're a rug. They view them as something that they're going to fall into. So for people who, by the door, we suggest black rugs by the door. If you have people that try to elope or wander, that might be a really good one. Again, warning signs on things. If like there's a garage door that you don't want them to mess with, do not enter signs from hardware stores, things like that. And then you can get these on Amazon or just different websites. This is a wallpaper. It's like a sticky wallpaper. And that's a door. So this is the handle and that's the frame. Oh, I forgot it's a touch screen. I always do that. Sorry. I don't know how to go back. Anyway, here we go. You can put them on doors that you don't want your loved one to go into. So like if you've got a basement door, things like that. it's really great. A lot of the facilities, memory care facilities, skilled nursing facilities, who might have a group of people that like to wander will use this as well. So just a couple of ideas. Oh, no.
Who would you buy something like that?
Online, typically online, on Amazon, alls.org, I think.
I think that you can also, like sometimes teacher supply places can have those door coverings and things like that too.
Yeah. Okay, so behavioral psychological symptoms of dementia. So I'm going to talk on this because it can get a little dicey in regards to somebody's behavior and how to address that. It's important to remember, again, with somebody with Alzheimer's disease is unable to reason. They are unable to reason. They are unable to come into the reality that you are. I had a caregiver once say to me, I can never be right. I can never be right anymore. And that's really hard. And especially if it's a spouse or if it's a loved one, a parent, you've had that relationship change almost overnight, it feels like, because this disease creeps up on you so slowly. And so I just want to take a space to honor that and understand that and know that that's a difficult thing to come through, as well as providing safety and care. So really the reality they create to make sense of what's happening within their life is not flexible. Common themes regarding abandonment include wanting to go home. If you hear somebody, I want to go home, I want to go home. We had a gentleman move his wife to their home, her childhood home. It happened to stay in the family in Ohio. And she kept saying it, and he was so confused because he kept saying to her, you are home, you are home. It's a place, or I'm sorry, it's a feeling, not a place. Home is a feeling, that safety, that security. So when somebody says, I want to go home, reassure them that they're safe, reassure them that you know what's happening and you've got it under control and you're going to take care of it. That can help. You also want to go through these things. Are they thirsty? Are they in pain? Right? Do they have a bed sore or some type of other kind of sore? All right. And then these, again, if you know somebody with Alzheimer's, you know one person, but these are really common behaviors. So some behaviors, while frustrating to the caregiver, can be soothing to the person with memory and thinking. I don't know if any of your loved ones come. Have you heard that? But it's what they've realized is it activates what's called the vagal nerve, and it can be very soothing to the person. So remember, this is due to the disease of Alzheimer's. It's not a decision they are actively making to get back at you or to punish you in any way. Speaking calmly and being aware of your facial expressions and body language, and Mary talked about this in communication. Listening to the concerns of someone living with dementia and try to avoid arguing or reasoning. Offering reassurance that your loved one is safe and you're there to help. And use other communications besides speaking, such as touching, back rub. Again, very, very helpful. Explain what you're going to do before you do it is really helpful. I'm going to give you your medication and some water for you to take with it, and then immediately give them that, right? So just so they can understand it, because sometimes even if they see you do it, they might not be able to process what you're doing. Show that you understand. If they seem agitated or angry, acknowledge that because they're feeling it. So you seem really worried. Let's sit down and go through some photographs. You seem really worried. Let's go outside and see if we can see Jimmy the squirrel. You seem really worried. Let's listen to some music, things like that. Take deep breaths, count to 10. Another professional likes to tell this story. A train went by at the same time every day, and that's when the caregiver was able to scream because they live close to a train. But really, truly, I say this deeply, we lose half of caregivers to this disease because it is so stressful, because you're not going to your doctor's appointments, because you're not being social with your friends, which is a huge protective factor in this disease, is staying social. So just being here today, you're ahead of the game. So thank you for that. And you're doing better than you expected. I'll just say that. So take deep breaths. It's really difficult. You've got a team. You've got the 24-hour Alzheimer's support. You've got Mary. It's really great how much resources are coming into the area. So that's something to be excited about. All right. So because a person with Alzheimer's disease has a brain disease, they can interpret reality very differently. Due to this disease process, trying to orient them to actual reality is impossible. As the disease progresses, the person with the disease may have hallucinations, delusions. So during a hallucination, they see things, hear things, smell things, or could taste things. And again, Dr. Bojarski said it doesn't bother them if they see the children playing in the yard and they think it's great and we're not going to do anything about it. Or they can be reassured when you go in and say everything's fine, I checked it out, and we don't want to do medication and cleanings. But just being in the reality with them can really sometimes help. And then he or she may also have delusions, which is false beliefs that a person thinks are real. And the biggest one really is paranoia. Right, you must have stolen my grandmother's necklace because I had it here in my purse and it's not here. Well, and they're just kind of I like to call it a pediddling, just pediddling here and there. But they have to make the reality to where they understand it. And if something's gone that they knew that they had, the easiest thing to say is somebody took it. And so instead of saying nobody took it, nobody took it, nobody took it, let's go look for it. Let's go look for it. All right, let's go have some ice cream and then we'll look for it, right? Changing the person's environment. If they're having a hard time, if they're really agitated, if they're really upset, just getting them outside if they're inside, getting them inside if they're outside does wonders for mood in general. For me as well. I love being outside. So I will say a caveat to that is if somebody continuously tells you something is happening or somebody's stealing from them, look into it. On a personal note, this was 20 years ago at this point, my cousin had my grandmother do a car note sign as a signer for a car. She stopped paying the payments. This was early in the Alzheimer's stage for my grandmother. My cousin stopped paying the payments and the bank was taking money from my grandmother. And we were all like, oh, Mama, you are just, this disease is just awful. Well, no, lo and behold, they were coming after her. She was getting debt collectors calling her because the cousin wasn't paying. So really, there is delusions, but with a kind of an asterisk caveat, make sure there's no financial abuse going on. If somebody's talking about that. Okay. Almost wrapped up here. Talked about that. Yep. All right. So we were talking about technology. Huge. This is great. So Google Home or Surrey, you can have medication reminders. You can have lists reminders, playing music. If you've lost your phone, you can say, find my phone, and your phone will start playing. And then this is a medication dispenser. I think it looks like kind of a Bluetooth speaker. I don't know. But this is the box. The medication will only dispense at that direct time. And if it doesn't dispense, so if your loved one doesn't kind of push that lever open, you get a text saying, the medication was not dispensed, and then you can call. This is one that we talked about. This is maybe for more early stage to mild, moderate, if you will. But those codes, check your email for the code to get on this access, whatnot. They offer a lot of apps, banking apps, email app, things like that offer face activation. If you could get somebody to set that up for your loved one so they can just look at their phone and it goes to exactly where they want it to go to, can be super, super helpful. Ring cameras or video home monitoring systems is huge. It's not just for the front door. Also, if your loved one lives alone, if you want to go to the Dollar Tree and get those fake cameras and just put it up by that door, because we had a gentleman knock on our participant's door and said, well, I got that lawn mowed and I got that tree cut down for you and all the brushes out back behind the house, and that'll be $1,000. That woman went to her checkbook and wrote him $1,000 check. Did not do a lick of work. So just again, for kind of safety monitoring, things like that, if you don't want to invest in a real camera, or you're waiting because, you know, all the technological issues with that, just one of those fake ones might be good in the interim. Safety alert systems have come a long way from help, I've fallen and I can't get up. There's little air tags you can have. You can make it as a watch or a bracelet. You can also, there's internet fees, but if they fall or whatnot, there's an intercom in the house that'll come in and say, are you okay? And then they'll also notify you if something has happened. The facilities. So, oops, I'm dropping money, pardon me. Labeled garments to aid in identification. Oh, wait, sorry, nope. For in-home landline services, for the safety alert system, can be around $20, and then in-home cellular service is about $30. But in regards to people who wonder, or who, you know, want to elope, let neighbors and local police know. There's group messaging apps that you can get on, that people can say, oh, you know, I saw Larry and he was at the Stop Mart. And they message, you know, Larry's son, and Larry's son's like, oh, Larry should be at home right now. You know, it just to kind of keep tabs on everybody. Let neighbors and the local police know and ask them to alert you immediately if the person is seen alone or on the move. Place their name in their garments if you can. A medical bracelet is always really good too. I think that's it for this one. But yeah, I'm excited to see more and more what technology goes through. Okay. So this is just for your all's information. It doesn't have to do with safety, and you can look at it later, but this just talks about the different types of dementias and how it affects people and what the symptoms look like. This is that home safety checklist that I was talking about. This is really great. It's for managing agitation, aggression, and sundowning. So it just gives you some advice on how to help ease that confusion, particularly when we see it late in the day, which is very, very common. And again, do's and don'ts in communicating with a person with Alzheimer's disease, and then firearm safety. All right, that's me. Hope I went within my time. Any questions?
Don't tell me about Westerns.
Oh, yeah. Thank you so much.
She can't watch Westerns anymore. I don't know what we're going to watch.
Honestly, the way that you're describing her behavior, like with Alzheimer's disease, lines get blurred. And so they think that it's happening in their house. They think that the shootout is happening in the living room. So I don't know if you have, Lawrence Welk. Did she ever watch Lawrence Welk? Anything like that?
I don't know, but listen, when I get tired of watching the Westerns, you know, Gunsmoke, Wagon Train, then I switch it to the Golden Girls or Reba.
There you go.
I switch it to those.
Keep it on Reba, keep it on the Golden Girls. I honestly, for the next 3 days, I would take Westerns and see if her behavior doesn't change.
Okay.
Truly.
No, because I mean, you know, that is just something that when it just started, she lived with my older sister. But when it got so bad that she couldn't take care of her, you know, I've had her for almost 2 years. And I can tell a big difference. Well, now let me ask you this question. The first week of July, we always go to my brother's.
Can I pause you there? I'm sorry. I'm just cognizant of time. I'd love to have this conversation with you one-on-one. But we're gonna let the resource ladies talk for just a second. Is that okay? Okay.
I just want to know, is it safe to take it?
We'll talk about it, yeah. And there's some things, there's some checklists that you can go by, but yeah, I'm not leaving.
You want us to just go ahead and get started and you still work on it? Okay. My name is Stacey Hall and I'm the Director of Aging Services at Big Sandy Ad. And I got Melissa King here with us. She's my Aging Programs Specialist. And we want to come today and talk to you all about local resources that we might can help you with your loved ones and for the people that's caregiving. We do cover the 5 counties in the Big Sandy region, which is Martin, McGoffin, Johnson, Pike, and Floyd. That is the counties where our services are located and we can help. We've been around for, 50 years, since 1974 with the Area Agency on Aging. A lot of people know about us, but then a lot of people do not. Kind of a, I don't know if it's a hidden secret, but I don't know.
Hidden gem.
Yeah. We have some of these, our programs might not be beneficial to you all. We're going to highlight some of the ones that we do have. And what's really unique about our agency is if you call our phone number that's on this brochure and you ask, hey, I need services for my mother, my niece, my daughter, whatever, they know where to send you because we have a one-stop shop, which is our ADRC program. And if you call in our building needing any type of service, resource, that is where you're going to be put to. And I'll let Melissa King talk about that because she was our ADRC coordinator for years. So let her talk about that and how that works. So you can't get lost of being transferred to one person. You know, here, if you call in needing help, they will get you to the right person.
So I am Melissa King with Big Sandy Ad. ADRC stands for Aging, Disability, and Resource Center. And as Stacey said, that is a one-stop shop. So when you call our agency and you say, I have a loved one who has Alzheimer's or dementia, and I'm looking for some services, they're automatically going to route you to ADRC. When you talk to either the coordinator of ADRC or the assistant or anyone in our agency that may be filling in for them on that particular day, they are going to discuss with you all our services that we have through our agency that they feel would be beneficial to you. They're going to talk to you not only about services that we may provide through our area agency on aging, but there may be other services outside of our building, such as the services like through ARH that we're going to say, we also have these resources. You may want to call and check on these. This is some of the basics about them, but you can reach out to, and we're going to try to get you linked up to anything that is available out there for you. One of our biggest programs that we have is the National Family Caregiver Program. It is a program that is designed specifically for you all, caregivers. We know that the care recipients are getting the best care possible. They've got you. We want to make sure our caregivers are being taken care of. In essence, with that also means the care recipients are getting better care because they're caregivers. So with the National Family Caregiver Program, we offer both aspects of that. We offer for the adult providers, caregivers, as well as grandparents or relative caregivers raising a grandchild or relative loved one. But with the adult piece of it, the adult caregiver, it is, as I said before, there is no money range on that. We do not care if you make $1 million a day. If you're a caregiver taking care of someone who is age 60 or older, then you qualify. That's basic. You qualify. The caregiver, have to live in the Big Sandy region, but the care recipient could live in northern Kentucky or anywhere. But the caregiver must reside in the Big Sandy region. With that program, some of just the basic services that we offer with that are, we offer you information. Of course, we want to get you linked up to any available resource that is out there and that can benefit you and benefit your caregiver. We want to offer you support groups and trainings, and we do try to partner up with other agencies to provide those support groups because we know you have very limited time and you can't be running to support group after support group after support group. So we try to partner up with anybody that we can to either offer it virtually or to make sure that we can provide you maybe some respite so you can get out of that. Of course, we offer free trainings. We try to bring in community partners to let you know about resources that are available. The two biggest things that we see in our area that folks are really reaching out for and have been reaching out for is the respite. We do provide some temporary respite. At this point right now, we're able to give 12 and a half hours a month. We realize that's not very much with the funding and in order to cover all the Big Sandy region. That's 25 hours every couple of months that you can get whoever you want to come in. You can get a friend, a neighbor, an extended family member. They just can't live in the home. But they can come in and give you a break. They can come in if you want to go sit down on the front porch and just take a break and know that your loved one is taken care of. You've got somebody in there and it's just your time. You want to lay down and take a nap. If you want to go get your hair done. If you want to attend church services on Sunday and not worry and know that you have somebody there, then we can help you with that. Again, it's free. We're not going to charge you anything to be on the program. The other big thing that we have is supplemental services. We go on what is called a fiscal year. So we go July 1st to June 30th, and each fiscal year you can request up to an amount, and this year it's $400, again, due to funding, but we're getting ready to start our new fiscal year, so that will be looked at again. Because each fiscal year, we look at those costs to see if we can adjust those and raise those for our caregivers. And so we are able to help with like insure the pins, checks, whatever the need is for the care recipient that's going to take some stress off of you. That's our goal. Our goal is we know we're not coming in there to alleviate stress. We know that. But we want to come in and offer, even if it just gives you a few moments, we want to be able to offer that to you so that you can get that assistance and know it's there and know that you have, an outlet that you can call. And not only are we going to try to give you some assistance, we want to link you to other resources that can offer you more assistance. Because with family caregiver, it is what is called a complementary program. So it's in there to complement any other program. You don't have to pick and choose. You don't have to say, oh, if I take this program, I can't get this program, because that happens a lot.
And we have some programs like that.
Yeah, and we do have
But not with that one.
The caregiver is complementary, so you could get services from us, and then like Christian Appalachian has Rejoice Respite, you could get their respite, and then you may be able to get respite through like Kentucky Home Care. And so there's just a lot of services that you can build together that you don't realize. Yes, it seems like 12.5 hours a month is not really worth it. But if you think about, well, I can take that 12.5 hours and I can put it with this 4 hours, and then you're building that respite time, and that can help you give that additional break.
And then a lot of times toward the end of our year, we can maybe provide another voucher.
Yes.
It's vouchers is what we provide. To spend the funding.
Yeah.
So
we do it on vouchers. So the way our vouchers works is once you've completed your application, you've submitted it. Our caregiver coordinator, Jeff Little, will reach out to you. He'll schedule a time to come out because he likes to meet caregivers. He wants to see if there's more services that maybe that he can offer or maybe he can refer to. But he will, once the initial part's done, then you will get a respite voucher. You'll get that once every 2 months at this fiscal year. Again, they will look at the new fiscal year starting July 1st to see what adjustments will be made. We may be able to offer more respite. We don't know that yet until we get our budget. But you will get a voucher in the mail. You will get whoever it is that you choose to come in and sit with your loved one. Again, it can be a family member, a friend, someone from your local church. It's who you trust, who you feel comfortable with. And especially with Alzheimer's and dementia, we also know that you just can't bring anybody in the world in. There is some confusion there, and they, it may work this time, the next time they come in, you may get somebody totally different because I don't want that person in there anymore for whatever reason, and that's okay. So the respite voucher allows you to use multiple people. And you'll sign that they are there. They'll sign that they were there. When you get the whole 25 hours used at his point, then you would get it back to Jeff. Jeff would submit that for payment, and the check would come in your name. Because if you have already paid that person up front, that is your reimbursement. If that person can wait until you get that check and you would cash it and give it to them. Each hour is worth $10 an hour and not to exceed $2. With that, we also get quite a few referrals through Kentucky Home Care. Kentucky Home Care is a program that is designed to assist in the home. Generally, it's one time a week that if you still have your loved one, maybe they're still living on their own, they're in the beginning stages, but you think, oh, they could use a little extra help in the home, you may want to reach out and find out about Kentucky Home Care. Again, it is a program that is designed to come and assist folks who are age 60 or older. We do cover all 5 counties, Johnson, Boyd, Martin, Dalton, and Pike, with things such as like light housekeeping duties, dusting, mopping, sweeping, potentially preparing them a meal. If they need assistance with like their personal care, they can help there. And then they can run errands for them. They need. They cannot transport them, but they can run it. They need them to run to the grocery store and pick up items. And that program is not billed through insurance. That is on what we call a sliding fee scale.
It's all state funded.
Yes, it's 100% state funded. So what will happen is once the referral is made to ADRC, and then they will get that to the appropriate case manager in the Kentucky Home Care. We have 2, Derek Fannin. He is in the back right there. He is our home care supervisor. And then we have Katie Sprigg. She's also a case manager.
Is that only here in this region, or do all the AAAs offer this?
All AAA offer.
Oh, no. It's not. I said you can
sliding.
Oh, yeah, you might have to pay a fee.
You may have to pay a fee, but it's not, I mean, it's not, you're not going to be denied it because
Okay.
yeah, you can always get, even if you have to pay the max.
Okay.
You can always get it.
And you're also, we can take off certain things off your income. If you're paying medical bills, paying for your medications. Derek, help me out. It's been a while since I've been.
Somebody to pay you some.
Transportation, if you're paying on.
Got an extraordinary bill that just pops up.
That can go off your yearly income. We don't look at anything like savings, stocks and bonds. It's all based on your monthly income. And then there's things that we can take off. And probably a lot of our clients, we have a few that have fees, but
some people
out of 80.
Out of about 80 that have a fee.
I think
it is as high as $7.26. So it's minimum wage basically.
Yeah. Yeah. And so if you think about that, that's about less than $15 a day. So it's a couple hours a week is like to.
And also we can do extra time, like say you get one time a week and another client's in the hospital and extra time opens up, you don't get billed for that extra time. You only get billed for that one time a week.
Yeah. So yeah. I think I know which program you're talking about. It's probably the waiver program because it is asset based.
And you cannot be eligible for Medicaid waiver and get this program.
And I know that
state rule.
That is one of the biggest things that's going on right now.
Yeah.
So if I wanted to do home care program with a local area on aging, call the ADRC number and say, I want more information about the Kentucky Home Care Program.
Yeah. And
but they want to train you for Medicaid waiver.
Because if you just call in and say, I need home care services, 9 chances out of 10.
They're going to say HCV.
Yeah. 9 chances out of 10.
You're still going to get screened.
You're going to get screened. And if you're eligible for waiver, and we'll go over waiver in just a moment, if you're eligible for waiver, they do have to do the referral for waiver. However, at this point right now, and because Medicaid does have a wait list, we are able to go ahead and start people on home care.
That's what I was going to ask.
Yeah. And their name gets pulled from the Medicaid wait list, which is really good. That's something we haven't been able to do up until this fiscal year. Yeah, this fiscal year. So that is something that's been really, really good. But with the Kentucky Home Care Program, again, like Stacey said, it is. Sometimes there is more time, but you have folks who may go out of town for whatever reason, and they may be going to be gone, or they may not be available to be there that day. They may have a doctor's appointment or something, and if there's an opening, then they could potentially offer it to you and say, hey.
What's the qualification to be in the program for home care?
You just have to be 60 years and older, and you have to have a physical limitation in 3 areas of daily living, or your daily living activities.
Okay.
Which, you know, it could be your ADLs, you know, or it could be personal care. We had some clients that just receive personal care sometimes. They don't need anything but personal care. They may have somebody that's in the house with them that's able-bodied to do the cleaning, but we can still provide personal care. We have some that do respite. You know, they might not need anything. No, they have caregivers in the home, but those caregivers need respite. You can get that by itself. So, yeah.
And it's really good. And again, it's really good because, like Stacey said, if you are an able-bodied person, they may not qualify for the cleaning piece of it, but you may need assistance with the personal care piece of it, and they could assist there. So that's really good. Home community-based flavor, that I know you all just heard us talk about that. That is asset-based. That is, it definitely is. I mean, it's income and asset-based. So what home community-based waiver is, and yes, they do have to screen the person for that and see if they would qualify for that. In the event that they do qualify for that, for home community-based waiver, then they would be referred to them. But again, right now where there is a waiting list with Medicaid, we can go ahead and serve them on Kentucky home care at this point.
You can go to traditional. You don't have to hire your own person.
Yes, yeah.
But I don't think that waiting list they might do.
I'm not sure with traditional. So with the home and community-based waiver program, the way it works is the person, that's whose income they're looking at. So say you have a married couple living in the home, and it's not dementia specific. It can be for any health issue. You have a married couple in the home. They're only going to look at the person who is applying for services, their income, because you are a married couple living in the home and you have couple assets, they are going to look at that. And that is for an individual who is single, widowed, divorced, that is $2,000 per asset guideline. And for a married couple, it's $4,000. So they do not look at your home that you live in and one vehicle. Everything beyond that, they do look at. If you own more than one vehicle, if you have any stocks, bonds, CDs, IRAs, money saved in the bank, anything.
Rental property,
anything.
But the home that you're living in, dwelling in, is not going to be counted as the asset?
Yes, it's not. You can have one home, yeah. They exclude your homestead.
And you do have to sign the Medicaid eligibility.
Yes. So with the program, the way it works is
estate recovery.
Yeah. The very first thing that you have to do is you have to apply for Medicaid waiver insurance. And you do that through your local Department for Community-Based Service. People commonly call it around here your local food stamp office. So you apply for that through them. They are going to talk to you about estate recovery. You are required to sign estate recovery.
Estate recovery is that death, they take over the.
Can.
They can. It's not a definite thing that they're going. There's some guidelines that go with that. Your estate has to value at a certain amount. If you have a surviving spouse or a disabled child who lives in the home, then they cannot do estate recovery because they cannot take that home away from a disabled child or a surviving spouse. So those are some ways. Not necessarily do they go back and do estate recovery. It is so Medicaid sets a budget, all right, and they may say, we're going to give this person. We don't know the budget, and you don't know the budget. Medicaid knows the budget, and it may be $1 million or $10 million or 500. We don't know. At death, they look at that budget. Did this person exceed that budget? If they did, then they look at their estate and their and they see, could we recoup any money from that?
From life insurances as well, or?
No, because if you have a life insurance, you have to sign that over to the funeral home of your choice in order to qualify for Medicaid waiver insurance. And it is an irrevocable, so you can't go back and get the money back. And once you sign it over to the funeral home of your choice, it's
even if the funeral home, those received already paid for. Still.
You have to be able to show because they count that as an asset. Anything over that $4,000 amount, they counted as an asset. So 2,000 for life, 2,000 for accident, or if it's an individual, 2,000. If you are transferring anything out of that person's name into someone else's name, has to be 7 years. I do go back 7 years. 7 now.
Nursing home. Is it nursing home still 5?
Oh, okay.
So they do go back and look at that. They do go
And
back.
they'll
and look
take
at that.
both your wages. Take his and yours.
In the nursing home.
We just wouldn't do that. They only go 5 years. And we were married 3 years. I said, that don't seem fair,
Right.
you know?
Yeah.
One of them is that he's married to his first wife 5 years ago. Take her money.
Any questions about their situation?
Oh, yeah, it is.
Yeah, very, very quickly, ladies.
Do not be deterred by all that because the benefits, in my opinion, outweigh the negatives. Yeah. At the end of the day, if they qualify and if they can get the waiver services, they can get 1 to 3 hours per week worth of services in the home. Potentially, you or someone you know could be paid to provide those services, or you could go, as she said, with traditional and go with an agency to provide those services. So please don't say, oh, this is all this, you know, check into it. Check into any service.
Right quick, we just want to mention too, we do have senior centers. Those are big resources for you all. We have 15 in our area, especially if they're still living alone and they're in those early stages and they're not driving, they can get a home delivered meal. They can be picked up, go to the center, be involved in activities, keep them, social to have socialization. They do health promotion. They do bingo signs, trying to keep them healthy. And even if they're in the later stage and you want to come and you're 60 years and older, hey, bring them.
Absolutely.
Yeah, come and join the senior center. There's all kinds of there's a lot of activities and resources that go on there. And education, they do nutrition education. You can get, your meal, which is they ask for a donation for the meal. There's never it's not a fee, but right. They do ask for a donation. But that's totally up to you if you can and can't. That goes with our congregate meals in the center and home delivery.
Familiar with that. Yeah, because I sit with this old lady once. She got her meals for everything.
Yeah, but I know there's a lot more that we do provide, but take our brochure.
Yeah. And the biggest thing is, I always reach out to our ADRC. Anytime we're there Monday through Friday from 4:30. If you have questions, if you think of something, even after you leave here, we are available to help. And thank you all.
Yeah,
thank you. Thank you all.
So we're gonna. You don't have to leave right now if you don't want to. But please kind of check out the tables. I do want to say thank you. Our memory clinic is new here. You can see that we're working with some great people to get it launched. We've had neurology for a few years. So you've met Mary. She's our navigator who can lead you through all of this. Like if you just want to reach out, you need a neurology appointment, you want to look at our services, all of that is free. We will tell you about if you want to stop at the table, if any of you guys are on Medicare, they have a brand new program that starts July 1st. That is free, no copay, that offers all those navigation services and $2,500 worth of respite. So our respite's a little bit different. You don't have to find somebody. We're going to send a home health aide for those 4-hour blocks of care. So if your loved one is on Medicare, stop by and talk to Mary or grab her card because that starts July 1st. But if you're not Medicare and you need other services like neurology appointments, you're interested in all of that. That's the other thing. We are starting support group July 9th. It won't be this long. This is considered a workshop. So on